Um, Good morning to all of you. I welcome you again to yet another edition of the Clinical Neurology Forum, which we have been holding every month. And it's my pleasure this month to invite Salem Medical College Department of Neurology from Government Mohan Kumaramangalam Medical College, who will be presenting the cases for presentation and discussion. And it's my pleasure to invite Professor Arul Selvan. Dr. Arul Selvan is an eminent neurologist of Coimbatore and a clinical neurophysiologist as well, and who has started the first MAGFUS, MRI guided focus ultrasound for Parkinson's disease in Coimbatore. And I again welcome Professor Shivakumar, senior neurologist and professor of neurology at Government Mohan Kumaramangalam Medical College in Salem, and who will be superannuating in just 2 months. So welcome all of you. And Arul Selvan, I hand it over to you to conduct the proceedings. Thank you.
Thank you, sir. Thank you very much. Good morning, everyone. At the outset, I would like to thank Professor V. Natarajan for giving this opportunity.
Thank you.
Almost for his relentless hard work, for continuous commitment for the teaching for the past several years, several decades, I would say that. And also thank the Sun Pharma for the unconditional support for this educational grant.
Yes.
Also congratulate them for them. I also invite Professor Shivakumar and Professor Thiruvarutchelvan, long-standing professor neurologist at Salem Mohan Kumaramangalam Medical College. I also welcome and thank the presenters Abhirami and Shashidhar, and then the last one, Sumita. I'll hand it over to Dr. Shivakumar, Professor Shivakumar, to conduct the proceedings.
Sumatira.
Sorry, sir, Sumatira.
The numerology, sir. Numerology, she has spelled it like this.
Oh.
Shall we directly go for the case?
Yes, sir. Yes, sir.
Good morning, everyone. First case will be presented by our exam-going third-year postgraduate, Dr. I think Abhirami is presenting.
Yes, sir.
Yes.
Just you can start now.
Yes, sir.
Arul, நீங்க start சொன்னா start
Screen
பண்ணு.
visible?
We'll start, sir. Let us share the slides. Let us share the screen, sir.
Yes, sir. Is that visible, sir?
Yes, ma'am.
Shall I start presenting, sir?
You can start now.
Yes. Good morning, sir. I'm presenting a case on interesting case of paraparesis. Mr. X, 38 years from Dharmapuri, sofa maker by occupation, came with chief complaints of burning sensation of both hands and feet for 3 years and weakness of both lower limbs for 2.5 months and sexual dysfunction for 2 months duration.
அம்மா ஏஜ் சொல்லணுமா? அபிராமி.
Patient was 38 years, sir. Yes, sir. 38 years, sir, from Dharmapuri. Sofa maker by occupation, sir.
Thank you.
Yes, sir. And presented with chief complaints of burning sensation of both hands and feet for 3 years, weakness of both lower limbs for 2.5 months, and sexual dysfunction for 2 months duration. History of presenting illness: patient was apparently asymptomatic till 3 years back. Then he developed insidious onset progressive neurological symptoms in the form of pins and needle sensation and burning sensation of it, which was symmetrical onset and gradually progressed over 2 months to ascend up to weeks. Initially, he was able to manage his work with these symptoms, but as days went on, he has abnormal perception of pain when he stamps on fiber dust during sofa making at his workplace, and so he left his work. As days further progressed, he developed difficulty to walk with bare foot. He feels shock-like sensation when he comes in contact with even finer clothes or wind. He started noticing burning sensation in both the upper limbs, extended from fingers to lower half of forearm for the past 1 year duration. No history of spontaneous ulcers. Symptoms started further worsening for the past 3 months. Now he is also having pins and needle sensation over the stomach. There is decreased perception of hot and cold water sensation in perineal and perianal region and in the lateral aspect of the left leg for the past 3 months. No history of numbness, walking over cotton wool-like sensation, and unsteadiness while walking in dark. No history of girdle sensation over the trunk, neck pain, or root pain. Then he developed progressive difficulty in using both lower legs for the past 2.5 months. He has to lift his leg higher than usual while walking, especially left more than right, so that the toes don't drag on the foot. He also had difficulty in sitting down and getting up from the ground without support, which is symmetrical. No history of difficulty in rolling over the bed and difficulty in getting up from the bed. No history of difficulty in gripping objects or lifting arm over the head. Able to mix foot well, button and unbutton shape, and able to reach for the objects that are kept at height. Where weakness is not associated with tiredness or stiffness. Patient noticed thinning of muscles over lateral aspect of the left leg without twitching of the muscles anywhere in the body. No history of diurnal variation or fatigability of weakness. No history of cramps. History of sexual dysfunction for the past 2 months. He can't be able to pursue penile sensation with difficulty in erection, which led to difficulty in orgasm. No history of loss of libido or nocturnal penile innocence. History of drifting of urine and soiling of clots at times associated with frequent voiding of urine. Able to pursue bladder sensation, initiate micturition, able to feel the passage of urine, could completely evacuate the bladder. No history of constipation or loose stools or fecal soiling of clothes. No history of aggravation in sensorial, speech, or emotional disturbance or seizures. Able to pursue smell normally. No history of blurring of vision, able to see in dark and able to differentiate colors. No history of drooping of eyelids, able to see well in all directions and no double vision. Able to pursue sensation over the face and able to chew well. Able to completely close the eyes and no deviation of angle of mouth or drooling of saliva. No history of hard of hearing, tinnitus or vertigo. No history of difficulty in articulation, swallowing and no nasal regurgitation. Able to turn head side to side and able to roll the tongue and swallow food. No history of unsteadiness while walking, clumsiness on reaching out for objects or involuntary movements. No history of slowness of activities, abnormal posturing or falls. No history of giddiness on getting up from bed. No abnormal sweating, chest pain or palpitation. No history of postprandial fullness. No history of vomiting, recurrent fever or joint pain. No history of trauma or weightlifting. History of significant weight loss of around 20 kgs within past 2 years. No history of genital ulcers. No history of bronchial ulcer anywhere in the body. No causing of high colored urine. No history of high risk sexual behavior. Past history. Not a known case of diabetes mellitus, systemic hypertension, pulmonary tuberculosis, or bronchial asthma. No history of connective tissue disorder. No history of chronic exposure to toxins. Treatment history. For the above complaints, he got admitted and treated as inpatient for 1.5 years back and had moderate improvement in symptoms, which lasted for 8 months, and he lost further follow-up. Personal history, alcoholic, used to consume alcohol daily of about 100 ml till 1 year back. Now complete abstinence for past 1 year. Non-smoker. Drug history, no chronic drug intake, no similar illness in any other family members. Summary. 38 years paid, so far assembler by occupation, previously used to consume alcohol, now abstinence and non-smoker, presented with chronic progressive neurological illness, symmetrical onset paresthesias of lower limbs, followed by upper limbs and trunk for 3 years, decreased perception of sensation in perineal and perianal region for 3 months, asymmetrical paraparesis, left more than right, involving both distal and proximal group of muscles for 2.5 months. Sexual dysfunction with urinary incontinence for 2 months duration. Without higher mental function, cranial nerve, cerebellar, extrapyramidal involvement, with intact bowel function, with significant weight loss of 20 kgs over past 2 years.
Upper limb symptoms, Amma?
Upper limb symptoms for the past 3 months duration, sir. Lower limbs only for the past 3 years, sir. Upper limb symptoms for the past 2.5 months.
Right.
Yes, sir.
Is there any postgraduate who's going to discuss?
Mm. Can anyone tell you whether it's an extramedullary or intramedullary or combination of both intra and extramedullary symptoms? Any postgraduates?
First of all, is it a cord lesion? Presenter, Abhirami ma.
Sir,
Abhirami, can you just
may-
start
may I
discussing?
proceed with-
Abhirami,
Sir, yes, sir.
what do you think?
Yes, sir. For me, the probable structures involved are peripheral nerves and predominantly small fibers, as evidenced by positive symptoms of pins and needle sensations, paresthesias, dysesthesias, and sometimes allodynia from both the lower limbs in symmetrical and upper limbs, and the perineal, perianal, and the trunk region. So I think peripheral nerves with predominantly small fiber involvements, and in motor complaints, it's asymmetrical distally and symmetrical, almost symmetrical proximal as per the history. So I would like with bladder symptoms and erectile dysfunction. So I would like to consider bilateral lumbosacral plexus or radicals also, sir.
Could this be from spinal cord? Could this be from the
Yes.
intramedullary lesion?
Intramedullary lesion, spinal bladder symptoms is only minimal symptoms he is saying in the form of inability to hold the urine and associated with the soiling of clothes, sir. So, and if it is,
He has loss
so
of
I like to
sensation.
perineal sensation and perianal both are there, sir. So, cardiac, if it is shown as sacral sparing will be there. Here, here perineal sensations are involved. So, cardiac, roots.
Complete பண்ணு காடா ஈக்குவேனா?
Cardiac, bilateral cardiac, along with the small fiber.
Yeah, bilateral காடா ஈக்குவேனா. Sorry. Very good. But see,
Yes.
first thing you will have to say whether it's a lower motor neuron lesion or upper motor neuron lesion in your view.
Yes. It's
Is this
lower motor element syndrome. Element syndrome. So sensory motor element syndromes.
right? So there's
Yes.
no symptoms features suggestive of a cord
Suggestive of
involvement,
cord in. Yes.
except for, as Arul has asked,
Bladder.
why has he asked whether it is intramedullary or extramedullary?
Bladder is involved, sir. So
Exactly.
So,
So
yes,
because of bladder involvement. So
Yes, sir.
can a bladder involvement be explained on a lower motor neuron lesion?
yes, sir. It can be explained. It can be explainable, sir. Because of
Oh.
the sphincter dyssynergia, sphincter and detrusor dyssynergia may be happen because of S2, S3, S4 root involvement.
So
But
it is when you
bladder.
have,
Yes,
so when you have a radiculopathy, you could have a bladder involvement,
yes, sir. Yes, sir.
right? Okay. What else is there in favor of a lower motor neuron involvement?
Associated with the wasting is there, sir, and there is no spasticity or pyramidal type of weakness in the history, sir.
What
Known
about
as normal.
what about the upper limb involvement?
Upper limb involvement is only a small fiber predominant involvement that involving both the dorsum and palmar aspect of the hand and extended till lower 1/3 of the forearm, sir.
So is that a lower motor or upper motor?
It is also probably lower motor.
So if it were to be a cord, lesion,
Yes,
if it were to be, where
Yes,
would you place the cord lesion?
Syrinx of syrinx CHE1 may cause this
That
the
again,
small
pathology. He asked where
Fine.
to the site of the lesion. Cervical cord or thoracic cord or
cervical cord. At CHE1 cervical cord.
So, okay. The second thing is, what do you think about the left lower limb involvement?
Left to lower limb involvement, both asymmetry is there, sir. It could be either due to progression of the peripheral nerves as mononeuritis, or maybe due to this radicular involvement, sir. Even though there is no radicular pain, I would like to consider both, sir, either for peripheral nerve or for radicals.
Even though there is no radicular pain, you already said it is a caudal lesion.
Caudal, yes.
So there is evidence of, if it is a caudal lesion, you have evidence
Yes,
of radicular involvement,
Yes, sir.
Right.
Cord. Yes.
What type of a bladder it is? Is it human or element?
It's like yeah, as per the history, I can't able to distinctly make out, sir. He is having
Because you mentioned
dribbling
that you
of
can
urine. Yes, sir.
patient can
Dribbling of
initiate and
urine
empty
is
the bladder.
empty the blood. Yes, sir.
Frequency is also increased.
Yes, sir.
And you have mentioned also some truncal sensory symptoms, isn't it?
Yes.
Truncal symptoms. Yes, sir.
Yeah. Why can't it be the cord is also involved?
It's a possible, sir. Only thing is there is no spasticity. That is the only point in differentiating, and there is no definite sensory level for this, sir. In trunk also, that's no definite sensory level. If it is cord involvement, there should be definite sensory level. In this case, there is no definite sensory level, sir. That also favors radical or small fiber rather than cords.
You will have to wait for the examination findings.
It's
But the question is, when there is a truncal involvement, what do you think is the truncal sensory involvement due to?
truncal sensory may be due to non-dependent small fiber neuropathy of truncal fibers also, sir. Dermal fibers, cutaneous fibers of not sensory.
It could be truncal radiculopathy also, isn't it?
Yes, sir. Yes, sir.
Radical involvement, truncal radical can also be get involved. Especially we see
It's-
a lot of diabetics. My
Yes.
question is, how often you see the bladder and bowel involvement in peripheral neuropathy?
Bladder and bowel involvement in peripheral neuropathy is very rare, sir. With the plexus involvement, we can explain this bladder, sir. Otherwise, bladder involvement is very much rare. So if it is autonomic involvement, we can think of. But as per the history, there is no giddiness or giddiness on standing or postprandial fullness or abnormal sweating. We can't explain with autonomic involvement. Sir.
Upper limb involvement cannot be explained by the lumbosacral plexus, isn't it?
Yes, sir.
Peripheral nerves.
So it starts like length dependent neuropathy
Yes, sir.
and becomes trunk involvement and the perineal involvement, bladder involvement.
Yes, sir.
So in addition to
And
the
sexual.
neuropathy,
Yes, sir.
maybe the spinal cord may also be involved.
Yes, sir.
But it
So
is
Abhirami, your conclusion at this stage, what do you think? Yeah, anything is possible as everybody has discussed. What do you think?
That's probable etiology.
On the structures involved.
Structures involved. I think in terms of peripheral nerves and roots, cardiac root, plus or minus bladder, sir.
Okay, now what do you think is the likely pathology or etiology?
Yes, sir. Probable etiology, it could be vasculitis of symmetrical onset, distal symmetrical sensory involvement, and chronic infections, HIV, Lyme's or leprosy, and connective tissue disorder related symptoms, neuropathy or neurosarcoidosis, and metabolic, alcoholic related or diabetes. Even though he is non-diabetic, I would like to consider pre-diabetic state from history. And paraneoplastic and neoplastic deposit. Paraneoplastic, I would like to consider because of the predominant sensory fiber involvement. And neoplastic deposit for this lower plexus involvement. So.
How do you relate the weight loss? 20 kgs weight loss.
Weight loss, yes, sir.
Do you think it's related or unrelated?
Yes, it is related, sir. So that only I'm suspecting this chronic infections of HIV or diabetes related, or could be paraneoplastic or neoplasm, which presenting with a significant weight loss of 20 kg, sir.
Did he have any pyrexia, fever, low-grade pyrexia?
No, sir. No fever history, no pyrexia like sickness in this patient.
You consider TB as an option?
TB as an option, but in a TB, peripheral nerve involvement like this is quite rare, sir. If it is arachnoiditis, we can expect, sir. But in arachnoiditis, severe pain will be there. In this patient, only paresthesia is severe, but radicular pain is not there. So I did consider it, sir.
He's a chronic alcoholic.
Chronic alcoholic, sir. For the past 20 years, he was taking alcohol of 100 ml daily, and now abstinence for 1 year duration, sir.
Right, Mario, listed out the differential diagnosis.
Yes.
What are the two top differential diagnoses?
One is primary vasculitis and second is chronic infections, sir. Two
Okay.
and the three and the third, I would like to ask the paraneoplastic and neoplastic. As he is having significant weight loss, I would like to consider, sir. 38 years of age, age. Liquid malignancies, I would like to consider, sir. Blood malignancies.
Right. If there are no further questions, if Arul agrees, perhaps you can proceed with the examination findings.
Abhi, you
Sir.
said there is some asymmetrical also, isn't it?
Yes, sir. Yes, sir.
Which infection will cause asymmetrical neuropathies?
Asymmetrical leprosy and mononeuritis pattern it can produce, sir. It can present in a asymmetrical pattern, sir.
Okay. You can proceed to the examination.
Yes. General examination is well built and nourished. No pallor, no pedal edema, no icterus, no cyanosis, no clubbing, no peripheral nerve thickening, no significant lymphadenopathy, no trophic ulcers or contractions. She was having hypopigmented hypoanesthetic patch in the anterior aspect of the abdomen in the left side. These two hyperpigmented marks are the post-biopsy marks. In this, we can make out one hypopigmented, ill-defined with ill-defined margin. And the patchy area of hair loss over the left anterior aspect of the leg, both thighs and trunk region. Vitals, blood pressure 120/80 millimeter of mercury, measured in right upper limb in supine posture. Blood pressure after 3 minutes of standing, it's around 110/80 millimeter of mercury. Pulse rate 88 per minute, regular in rhythm, normal value, no normal volume, no specific character, no radial or radiofemoral delay. Respiratory rate 16 per minute, regular, abdominal thoracic type of breathing and temperature normal. Higher mental function, patient conscious, oriented to time, place and person, MMSC 27/30, memory immediate, short-term and remote memory is intact, language and speech normal. Cranial nerve examination, olfactory cranial nerve normal, no anosmia or parasmia, visual optic visual acuity 6/6, color vision, field of vision and the fundus within normal limits, and oculomotor nerve, no ptosis. EOF full in all directions, no nystagmus, no squint, direct and indirect light reflex normally present. Sensation over the face normal, muscles of mastication had full power, and jaw not absent, and the corneal and the conjunctive reflex normally present. Facial nerve, no facial asymmetry, normal wrinkling of forehead, force eye closure normal, blowing of cheek normal, bilateral nasal labial force, no asymmetry, no deviation of angle of mouth. And the vestibulocochlear nerve, normal, Rinne's test positive, that is air conduction better than bone conduction, and the Weber not lateralized. Glossopharyngeal and vagus nerve, uvula decline, palatal movement symmetrical, and the gag absent. Final accessory nerve, turning of neck and the shrugging of shoulders normal, hypoglossal nerve, no fasciculation, no deviation of tongue, and power normal. So no cranial nerve involvement in this patient. And spinomotor system, asymmetrical wasting seen in bilateral leg along the anterior aspect, left more than right, and the difference of about 2 centimeters was spread out in leg. And the tone normal in all 4 limbs, neck power good for both the flexion and the extension. And for shoulder, abduction, adduction, flexion, extension, internal rotation and external rotation 5/5. Elbow, flexion, extension, supination and pronation is also 5/5. And wrist, the flexion, extension is 5/5. Small muscles of the hand, power, all thenar, hypothenar, lumbricals, intraosteus, finger flexors, and finger extensor is good. And coming to lower limb, hip flexion 3/5 on both sides, extension 3/5 on both sides, and abduction 4/5 on right and 3/5, mildly asymmetry, and adduction 4/5 on both sides. Knee flexion and extension 4/5 on right and 3/5 on left. And dorsiflexion and plantar flexion, dorsiflexion affected more in the left leg, and plantar flexion 4/5 on both sides, and the intrinsic muscles of the foot is also weak. Superficial reflexes, superficial abdomen reflex absent in all 4 quadrants. Chromastic reflex present in the right and absent in the left side. Anal reflex absent. Plantar bilateral withdrawal response. And deep inner reflexes, jaws is not elicitable. Biceps, triceps normally present. Supinator jerk 1+ sluggish, and lower limb knee jerk and ankle jerk 1+. Hyporeflexia normally present reflexes in the upper limb and hyporeflexia in the lower limb. Sensory examination, pain and temperature, patchy area of sensory loss over the tongue, trunk, both thighs, and left pectoral region and left shin with perineal and perianal sensory loss. Hyperesthesias over bilateral hands and feet. Proprioception and vibration normally persist and rhombus sign was negative. Gait walks with high steppage gait, left more than right, characterized by excessive hip and knee flexion during the swing phase. And cerebellar examination, test of coordination, finger-nose test, finger-nose test, and if normally present, no intention tremor, no displayed of kinesia, heel shin test and toe finger test, normal. Tandem walk able to do. Spine and cranium, normal, no signs of meningeal irritation. Autonomic nervous system, no orthostatic hypotension, no resting tachycardia, no peripheral nerve thickening. Systemic examination, respiratory system, bilateral RNC equal, no added sound. Cardiovascular system, S1 is to normally heard, no murmurs. And per abdominal examination, soft, no organomegaly. So summary, sir. 38 years old male, chronic progressive sensory motor disturbance for the past 3 years. On examination, he had a hypopigmented and a hypoanesthetic patch over the abdomen with patchy areas of hair loss over the trunk. Asymmetrical paraparesis, left more than right, distal more than proximal, with preserved dependent reflexes in upper limb and hyperreflexia in lower limbs. Decreased perception of pain and temperature in lateral aspect of the left side, perineal and perianal region, with areas of hyperesthesia with preserved vibration and proprioception, without higher mental function, cranial nerves, cerebellar, and autonomic involvement.
Shivakumar sir, you want to ask?
We can discuss the case. Any postgraduates from other institutions, if they are attending, they can discuss. Otherwise, presenter can discuss.
They are attending, but I do not know whether they will be coming forward to discuss. Okay, ma.
Presenter can discuss.
Abhirami,
Yes, sir, may I proceed?
so how has the examination helped you?
Yeah, in examination, same structures are involved is in favor of as discussed in history, like peripheral neuropathy and radical involvement of lower limb. And I could find a hypopigmented and hypoanesthetic patch over the abdomen and patchy area of hair loss over the tongue. That is one additional point from the examination, sir, that I could made out. But there is no any peripheral nerve thickening.
What do you mean by peripheral neuropathy?
Peripheral neuropathy.
You said peripheral neuropathy.
Yes, sir.
What do you mean by peripheral neuropathy here?
Peripheral neuropathy, what I mean is, sir, since a small fiber involvement, sir, in the form of a paresthesia is there. Only positive symptoms without negative symptoms is there.
The SAR is asking which one?
Hyperesthesia, decreased perception of pain and temperature in the perineal and perianal region. I would like to consider both peripheral nerve and radical.
That's okay. Then you said peripheral neuropathy. Peripheral
Yes,
neuropathy is usually associated with symmetrical involvement,
yes, sir.
correct? Of
Yes,
both large and small fiber involvement,
Yes, sir.
usually more distal than proximal.
Yes, sir.
Does this presentation examination findings, does it fit in with that? Are there red flags to say it is a peripheral neuropathy? If so, what are the red flags?
Red flags, weakness is predominant in the proximal group of muscles. Not then perineal and perianal sensory loss is a red flag, sir. Along with that,
That's correct, yes.
that is one finding. Along with the bladder involvement and sexual dysfunction. Sexual dysfunction may also, but yes, sir.
My question is,
Yes, sir.
you said peripheral neuropathy.
Yes, sir.
I am asking you the red flags for a peripheral neuropathy. If you talk about motor, finish the motor. Then if you want to discuss the sensory, what is the red flag in the sensory presentation? Then of course, the bladder involvement is another one.
Yes,
So
sir.
what is unusual for a peripheral neuropathy as far as the motor system is concerned?
As far the motor system is concerned, symmetrical proximal is the
Peripheral
red flag.
neuropathy, Abhirami, peripheral neuropathy
sir.
starts distally,
Yes, sir.
and it goes up. The weakness starts in the foot.
Yes, sir.
Then it goes up, then weakness progresses up to knee, then upper limb involved. That is a typical peripheral neuropathy.
Yes,
Here
sir.
it is unusual. Patient has got
Yes.
more proximal weakness, proximal
Yes,
plus
sir.
distal. So the lesion involvement is proximal, more
Yes,
proximal in the
yes.
peripheral now. So typically,
Yes.
it's not a typical peripheral neuropathy.
Yes. Yes.
Proximal weakness. I
Yes,
asked you
sir.
to discuss the motor involvement. What is the proximal weakness here?
Proximal weakness of hip, difficulty in sitting down and getting up from the
No.
squatting.
Are
Sir.
you-
No,
Adduction,
hip flexion is
flexion,
there.
extension,
Which
flexion.
muscles? No, Abhirami.
Yes, sir.
Which muscles? You presented that. Which muscles
Yes.
are weak? Which muscles are weak?
Pelvic muscles and the extensors and the hip extensors, flexors, abductors, adductors, and the knee flexors.
No. Hold on.
Yes, sir.
They are not equally involved as per
Sure.
your presentation.
Yes, sir.
Flexors and extensor are more involved.
Yes, sir.
Abductors and adductors are not that much involved.
Yes,
So
sir.
there is a differential involvement
Yes, sir.
of even the proximal muscles. It's
Yes, sir.
differentially involved.
Yes, sir.
Flexors and extensor are more involved than
Yes.
abductors and adductors. Why
Yes,
it
sir.
becomes important, how it becomes important, you will have to discuss. That's one finding.
Yes, sir.
Then significant. See, the flexors and extensors of the hips, you said is 3/5 power.
Yes, sir.
Correct? Abductors and adductors are 4 or 4 plus.
Yes, sir.
Then knee flexors and extensors are 4.
Yes, sir.
Coming to the ankle one side is dorsiflexor is 3.
Yes, sir.
So you seem to have an asymmetrical distal involvement with the symmetrical proximal involvement, but a differential involvement.
Differential involvement. Yes, sir.
So all these things are important to construct where is the site of involvement.
Yes, sir.
At least motor. I'm
Yes, sir.
discussing only motor.
Yes, sir.
So
Yes.
so what do you think of this motor involvement? What do you make out of this motor involvement?
This
What do you
motor
think is-
involvement
Yeah, what is
maybe
the site?
because
you
of
think?
peripheral nerves, sir. Mononeuritis multiplex may present with this the differential power involvement.
Exactly. So
Yes,
you consider separate nerves which are being involved. You brought
sir.
in mononeuritis multiplex.
Multiplex. Yes, sir.
This is different from the peripheral neuro. Even though this involves the peripheral nerves, this
Yes.
does not constitute a peripheral neuropathy in the sense which you mentioned.
Yes, sir.
So
Yes,
this distinction becomes important.
yes,
Now
sir.
you brought in a mononeuritis multiplex.
Multiplex. Yes, sir.
Right. If it is not mononeuritis, I mean, that is one. Certainly, that's one differential for a structural involvement. What
Yes,
would be
sir.
the other differential diagnosis for a structural involvement based on
Right.
motor? Yes.
If it
Yes.
is radicals, then it
Correct.
Yes.
So these things come first. If it
Yes,
is a peripheral nerve, it will be a mononeuritis multiplex like presentation, or
Yes.
it should be a radical. So
Yes.
which do you think is more? Okay, you will consider that both.
Yes, sir.
Now you go on to the sensory findings.
Yes, sir.
Then what do you think? What about the sensory findings?
Sensory findings, perineal and perianal sensory loss of S2, S3, S4, sir. And I would like to consider pudendal nerve involvement, sir, because S2, S3, S4, both perineal and perianal, and the lateral aspect of the lateral cutaneous femoral nerve, I would like to consider for that, sir.
Okay,
Sensory.
since you brought it in, the relative foot drop on the left side
Yes, sir.
and the sensory on the lateral aspect of the leg,
Yes.
would you consider it to be a sensory motor neuropathy? If so, which nerve?
Foot drop and sensory.
Yes. Which nerve?
Sciatic.
Sciatic is formed by sciatic gives rise to which nerves?
Yes. Common peroneal and tibial nerves.
Correct. Now, what
Yes.
is this weakness and sensory deficit pointing to?
Common peroneal.
Exactly. When you are talking of a mononeuritis multiplex, these are the things which suggest that it may be a motoneuritis multiplex, or
Yes.
if it's a radiculopathy, which
Yes.
radical?
L5 and the S1. Foot drop is L4.
Yes.
Yes.
So it's either those radicals or it is peroneal nerve involvement. Right.
Yes.
So far, so
Yes.
good. Now, what about the sensations itself? Sensory involvement is suggestive of what? There is
Sensory
a
involvement.
there is a differential sensory involvement,
Yes, sir.
right? You have been
Yes, sir.
harping on that often. Sensory involvement is a small fiber rather than a large fiber. It's whatever you said is pain and temperature.
Yes, sir.
You said vibration is preserved, no
Yes, sir.
wrong birth. Yeah.
Yes, sir.
So it suggests that it is a selective sensory involvement of the small
Selective
fibers.
Yes, sir.
Right. So that also you have to include in your discussion. So this is this more in keeping with the radicular involvement, or is this more in keeping with the mononeuritis multiplex involvement?
More in favor of a mononeuritis multiplex
See,
involvement.
Amma, this is how you will have to discuss the case, Ma. Take
Yes,
each
sir.
finding, and based on that finding, you come to a
Yes.
conclusion as to what is more likely.
Yes, sir.
It becomes difficult.
Yes,
Okay.
sir.
and
Yes, sir.
now the more difficult part is explaining the bladder involvement.
Bladder. Yes, sir.
Of course, with an absent anal reflex.
Yes, sir.
So what do you think of that?
Food and nerve involvement, I would like to consider, sir.
Yeah, we have two differentials here, structure wise.
Yes.
That is mononeuritis multiplex or a radical.
Yes, sir.
So if it is mononeuritis multiplex, what you already said, it's a possibly epidendral nerve involvement.
Yes, sir.
Unilateral, bilateral.
Bilateral.
So it's bilateral.
Yes, sir.
What are the proximal motor nerves that is involved? You said left hip flexion, left hip
Yes, sir.
extension.
Superior gluteal nerve and the inferior gluteal
Can you go
nerve
back to
along with stem.
can you go back to that slide, Abhinami?
Yes.
Left hip flexion is weak. That is 3 by 5, isn't it? Which
Yes,
nerve
sir.
causes hip flexion?
Femoral
Femoral nerve. Knee extension.
knee extension. Hip
extension.
extension is gluteus maximus, medius, and minimus, sir.
Gluteal nerve.
And abduction is gluteus.
Oh, Abhinami,
Yes,
hip
sir.
extension or knee extension?
Hip extension.
Hip extension.
You said knee, hip extension.
Hip extension. Yes, sir.
Knee extension is also weak, but we'll come back to that point. So
Yes,
hip
sir.
flexion is weak, hip extension is weak, superior gluteal nerve, femoral,
sir.
hip
Yes, sir.
abduction, again gluteal.
Hip abduction again, gluteus muscle, sir. Medius.
Adduction.
Hip adduction, adductor, sir. Adductor magnus and
Which nerve? Obturator nerve.
arbitrator. Yes.
Proximally also you have a differential involvement. You have involvement of the femoral nerve, you have
Yes,
involvement of the superior gluteal nerve, you have involvement of the obturator nerve,
Yes, sir.
then peroneal nerve. If it is nerve root, where do you place the lesion? If it is nerve root,
Yes, sir.
which nerve root causes hip flexion?
L2, L3, L4, sir. Hip flexion and extension by L5, S2.
Okay, thank you.
Yes.
Yeah, it's a difficult problem, and that's why you are presenting the case. But
Yes, sir.
this is how you will have to analyze.
Yes.
Okay, proceed further. Now we have
The sensory loss over the trunk that she has mentioned.
she has
That
to
needs to
mention,
be discussed.
and also she's made a note that there is a hypopigmented patch.
Yes, sir.
So that also is important, becomes important, particularly when you consider a mononeuritis multiplex-like presentation with predominant small fiber involvement.
Yes.
We are discussing an atypical case. Obviously, we know it's an atypical case. There are going to be surprises. So you will have to consider all possibilities.
Yes, sir.
So what about, we were discussing bladder, we were discussing about the bladder involvement. So you think it's a bilateral pudendal nerve involvement?
Yes, sir.
Okay.
Bilateral.
Or which radicals?
S2, S3, S4.
Okay, you already made a note of that. Right, fine. Yes, Arul and Shivakumar, any further discussion on this anatomical sites of involvement?
The only thing is that truncal sensory loss that has to be taken into account, sir. Patient's problem is not confined only to lower limbs. It's also trunk is involved.
And upper limbs.
Upper limbs also some sensory loss is there.
Correct. So
multiple radicals is a possibility, sir, or multiple peripheral nerves.
Correct. So same, we are still discussing either mononeuritis multiplex like presentation or a radiculoneuropathy presentation. Am I right, Abhirami?
Yes, sir. Yes, sir.
Sir, my doubt is, allegation, sir.
Tell me,
நீங்க
sir.
தான் சார் ப்ரொஃபசர், நீங்க சொல்லுங்க சார்.
Yes, sir. Is the broader symptoms are typical with mononeuritis multiplex?
No,
இல்லை.
no, no.
இல்லை.
That's why sir said that it is a red flag.
நீங்க சொல்லுங்க allegation. What do you think? You
Yeah,
think
I think because of this sweating and autonomic disturbances, can it be due to any plexus involvement?
என்ன அபிராமி?
Plexus autonomic.
ஃபர்ஸ்ட் ஸ்வெட்டிங்கோ எதுவும் இருக்கா? ஆட்டோனாமிக்
Yes,
டிஸ்டர்பன்ஸ் இருக்கா?
no autonomic symptoms or disturbances.
அத முதல்ல சொல்லுங்க.
Yes, sir.
Hmm.
No
So,
autonomic
The
disturbance.
question is, can it be plexus involvement?
Plexus involvement, roots, plexus.
How does bladder involvement pin it or localize it to a plexus rather than a radical or a peripheral nerve? What is a plexus after all?
I couldn't make out, sir. In plexus also, because of this parental nerve and sympathetic fibers only involvement. Per se, I can't able to say, sir, how could bladder may involve with the plexus. I can't able to.
Allegation, sir. எதுக்கு plexus ஒன்னு கொண்டு வரணும் இப்ப? We already said radical and nerve. Why do we want to bring in a plexus? Is it exclusively only a plexus lesion? Allegation, sir.
Yes, sir. I just thought of because of the autonomic symptoms, sir. And the,
இல்லம்மா, அது இல்ல, no autonomic symptoms.
okay, sir.
So continue, Abhirami.
Yes, sir. Thank you. Investigations.
Wait, don't run away.
Yes.
The anatomical side, we said you are comfortable with a radiculoneuropathy or a neuroradiculopathy, correct?
Yes, sir.
And that
More
too small fiber involvement neuropathy.
Yes, sir.
இப்போ etiology போங்க. What produces this sort of
Abhirami, small and large fiber. So you have got a weakness also. Motor
Yes, sir. Weakness.
sensory motor neuropathy, diffuse,
Yes, sir.
and
Yes, sir.
probably multiple nerves or multiple radicals.
Yes,
Small
sir.
fiber as well as motor fibers, which are larger fiber.
correct
Sensory is
motor
bad.
neuropathy, but the sensation. See, we need to we are making a differential involvement of the sensory. We are saying
Yes,
it's pain and temperature more than the large fiber sensory fibers.
Yes, sir.
So that might add another dimension to the etiology, Sivakumar. Another, we are making the
Yes.
differentiation.
Yes,
Okay.
sir.
சொல்லுங்க அபிராமி.
Along with hypopigmented patch and this predominant small fiber with the mononeuritis multiplex pattern, I would like to consider chronic infection of leprosy, sir.
Good.
Yes, sir.
Okay.
Yes.
It need not be. Now, what are the differentials?
Other differentials are primary vasculitis, primary peripheral nerve vasculitis. I would like to consider, since there is no any other constitutional findings or symptoms as per the history and examination, like arthritis or other system involvement. I would like to consider primary peripheral nervous system vasculitis, sir. Then second is then again I would like to consider other chronic infections like Lyme and HIV also, sir. Since different weight loss is there. And last one is neoplastic plus paraneoplastic syndrome. Neoplastic deposits with paraneoplastic. So paraneoplastic predominant sensory, but the mononeuritis pattern in neoplastic and paraneoplastic is not quite common. So that is least likely to be.
Another red herring here is, see, weight loss,
Yes,
the peroneal neuropathy can be
Yes, sir.
associated with weight loss. Because it could be a pressure-induced neuropathy. But
Yes,
of
sir.
course, it's unilateral. I'm just
Yes,
saying that is one of the possibility you will have to consider. Only for
Yes.
that reason, peroneal involvement.
Yes, sir.
Right. Arul and Sivakumar and allegation, do you have anything else to ask her, or shall we proceed with the investigations?
No, sir. We will proceed with the investigation.
Okay, sir.
Yes. Investigation. The white blood cell count 7,200 and HP 11.6 gram per deciliter and platelet 3 lakhs. Urea 23 milligram per deciliter, creatinine 1.1 and bilirubin 1.4. SGOT, SGPT and LDH were within normal limits, and serum calcium is of about 9, and serum vitamin B12 level is 950 within normal limits, and the CRP of 8. And ESR is elevated for the 30 minutes, it is 56 millimeter, and for 1 hour, 145 millimeter. VCTC not reactive. Anti-HCV is also not reactive, and HbSAg not reactive, peripheral non-reactive. Peripheral smear shows normal steady. And for vasculitis circumstance, we did ANA, which is 1 plus nucleolar pattern in a 1:60 dilution, and C and K, both are negative for this patient. And CSF analysis we did, it showed sugar of about 44 milligram per deciliter and protein 66 milligram per deciliter. Cell count 5 cells, predominant lymphocyte C. And cytology, no abnormal cell morphology was seen. And CB0 for Mycobacterium tuberculosis, that which is not detected. And shall I proceed with the nerve conduction?
Yes, go ahead.
Yes.
We don't have much time, ma. You have 2 more
Yes.
cases.
Yes, sir. Nerve conduction study. Central nerve conduction study, right median, IR left median, nerve conduction velocity was reduced, and bilateral sural nerve not stimulatable, and motor nerve conduction velocity within normal limits. And as he was having
One minute.
Sorry to interrupt.
Motor conduction, you will have to talk about the amplitudes. See,
Yes.
already Sivakumar pointed out that is a motor nerve involvement also to account for the weakness. So what about the amplitudes of the motor nerves?
Normal pressure.
The tibial is 10.3, peroneal.
Tibial is right tibial and the left tibial 10.2 and 8.5, sir, and peroneal 3.4, sir.
3.4, and another left peroneal, I can't see.
Left 2, sir. 2, sir.
Left peroneal is 2. Little bit.
Yes, sir.
What about the F wave latencies, ma?
Yes.
F-wave latency, sir.
Be coming in another table, ma. Another table.
F-wave latency here.
If
we
you
will
most
show,
important, isn't it? That will give you
Ma, zoom pannuma. We are not able to see. I am not able to see F wave latencies.
FA with the sir.
Yes, sir. She has not included.
Sorry, நீ சொல்லு. Include பண்ணா பரவாயில்லை. நீ சொல்லு.
F-wave latencies are around normally present, sir, at this 35, sir, in 35 and 33, sir, in both upper limb and the lower limb, sir.
That's abnormal.
மாமா, ஒரு நிமிஷம். Lower limb எவ்வளவு சொல்றீங்க? Lower limb எவ்வளவு சொல்றீங்க?
35, sir.
Lower limb
lower
is not, that's not normal, no?
ஏங்க lower limb
will be around
35
50.
வருதா உங்களுக்கு?
Lower limb
Yes, sir.
upper limb
Lower limb,
upper limb
lower limb 35.
Ma, no way அது. You can't have 35 in the lower limb. Forget it. நீங்க பண்ணலனா பண்ணல சொல்லுங்க. நோட் பண்ணலனா நோட் பண்ணல சொல்லுங்க. ஏதோ ஒரு நம்பர் சொல்ல கூடாது.
Sir, it was around, I can't able to recollect, sir, sorry.
என்னம்மா?
I can't able to recollect this, sir, sorry.
சரி, we don't have it. அவ்வளவுதான். Proceed. அது அருள் செல்வன் டிசைட் பண்ணிக்கிட்டோம்.
FA will be very crucial in this because in
Exactly.
nerve involvement or plexus involvement. So generally upper limb FA latency more than 32 is considered as abnormal, and lower limb is more than 55 is considered to be abnormal for the Indian subgroup population.
So அதனால 35 lower limbலாம் வரவே வராதுமா. Not acceptable.
Sorry, sir, I can't able to.
Okay. See.
Then slip skins where we did it was negative, and serum electrophoresis showed normal pattern, and whole body PET in view of neoplastic condition we did no abnormal metabolic activity was seen. And MRI we proceeded with the MRI lumbosacral spine with the contrast. In that we saw contrast enhancement of bilateral lumbosacral roots left more than right, and X-ray, chest X-ray normal, USG abdomen and pelvis was normal steady. And then we proceeded with the biopsy of
inflammatory screen பண்ணியாமா inflammationக்கு
CANCA
ESR and CRP we did, sir, and CANCA PANCA vasculitis workup also we did, sir. It's all negative.
ANA is 1 plus.
ANA 1 plus.
ESR is grossly raised.
Right.
ஆமா 125 very grossly
140.
very grossly increase.
Yes, sir.
இந்த bilateral lumbosacral enhancement சொல்றியே inflammatory அது.
Inflammatory, yes, sir.
So and protein also is raised. CSF
Yes,
protein
sir, 66.
66.
Yes, sir.
So we are talking of some inflammatory process going on.
Yes.
Continue.
And the nerve biopsy of left sural nerve done, it showed chronic neuropathy, and the skin from the abdomen we did biopsy, and it also showed non-specific inflammation. So the diagnosis of chronic inflammatory polyneuropathy and lumbosacral radiculopathy of vasculitis we considered, sir.
Why not a CIDP, ma?
CIDP age is 38, sir, and it asymmetrical weakness.
So is that the reason? What is the main reason?
Relapsing under the
No.
Nerve conduction.
and the nerve conduction is normally not nerve conduction motor amplitudes are
It is
normal.
based on your nerve conduction studies.
Yes, sir.
அது சொல்லணும்ல.
Yes, sir.
That is most important.
Yes.
Okay.
Yes.
In fact, we should have considered in the differential diagnosis a CADP also. We did not.
Yes.
But of course, your nerve conduction study excludes it. Am I right, Arul?
Yes, sir. But the bladder involvement is also there, isn't it?
Atypical. Yeah, obviously discussing atypical presentations. Sorry. இதுக்கு வந்து out of the blue, I am saying, Mogart பார்க்கணுமா?
Mogart, peripheral. Age is 38 years of age.
Lumbosacral
plexus cardiac.
Lumbar radicular inflammatory lesion.
Yes, sir.
Would you consider? I mean, at least should we consider the differential diagnosis? Mogart.
Yes.
Okay, go ahead.
Then, here in a
go back to the nerve biopsy. Does it show
biopsy. Go back to the biopsy. Yes.
Does it show any inflammatory cells? Scattered lymphocytes are noted in the endothelium around the perineural vessels. No transmural inflammation. Okay.
Lymphocytes are very scattered, sir. Not much of inflammation.
Not much of vascular involvement also. No evidence for vasculitis.
Yes, sir. Only
vasculitis only skin biopsy தான் எடுத்தியா மசிலும் எடுத்தியா?
இல்ல sir, only skin biopsy.
அதுல தெரியும் மசிலும்
Yes, sir.
You should have taken the muscle also.
Muscle also. Yes.
If there is a proximal motor nerve involvement, you should take the muscle biopsy also. Then only you can see that whether intramuscular nerve involvement or not. So we always think about the sural nerve biopsy plus muscle biopsy. That will give us some more information.
Yes.
So our conclusion enna?
Sir, they simply said that non-specific inflammation of both skin and the chronic neuropathy of nerves, left nerve, sural.
அது வந்து நான் ஸ்பெசிஃபிக்கால கொடுத்திருக்காங்க. எங்க
Nimhans, sir. Yes.
Nimhans.
Yes, sir.
She has one more slide, sir.
Please go ahead.
Yes.
Please go ahead.
And this is PCR biopsy of skin, PCR of skin, sir. PCR.
Excellent.
And it is positive for Mycobacterium tuberculosis, Mycobacterium DNA, Mycobacterium leprae DNA. Sir.
No.
Excellent.
Yes.
Very good.
But they didn't show at the nerve biopsy. They didn't strain for the lepra strain.
They have looked for it.
They have mentioned, sir, but they no positive for a granuloma.
They have looked for it. They have said specifically no evidence of leprosy. Coming on the slider.
Yes, sir.
Remand slider.
Yes.
அது கொஞ்சம் ஜூம் பண்ணுங்க. அதுல மென்ஷன் பண்ணிருக்குன்னு நினைக்கிறேன். ஜூம் பண்ணுங்க.
Slide மட்டும் zoom பண்ணுங்க.
அந்த ஸ்லைடை ஜூம் பண்ணுங்க.
Negative, sir.
அதுல எங்கயோ பார்த்தேன்னா
Yes, sir. It is here, sir. From below, from third line, 5 Farrakpo strain of lepra bacilli is negative.
Correct.
Yes.
Strain is negative. Right. Very good.
That's
So
really
your first diagnosis amongst the differential diagnosis is correct, right?
Yes. Yes.
Yeah, now we have certain difficult questions to answer. How are you going to answer that? How are you going to explain the proximal involvement? How are you going to involve, as the allegation asked, the bladder involvement? How are you going to explain on the basis of Hansen? Any literature evidence for that, Tuma?
Literature is there, sir. Where in one, they showed 29 cases they have studied, sir, in leprosy. In that, plexus involvement was seen around 17% of cases, sir. So plexus involvement,
What was it?
17% of plexus involvement, sir.
Plexus illa. We are talking of bladder involvement.
Bladder, this, what I couldn't find in relevant literature.
Then you
Case
should,
report.
you should write a case report.
Yes.
Allegation. Unga comments allegation.
Yes, sir. The moment she shows the skin lesion, the diagnosis is obvious, sir. It's leprosy only. Because I think 2 months ago.
Findings.
Yeah.
How do we explain the findings?
Findings this patient has got.
Baaki ella explainable. How do we explain the bladder involvement?
That's what I am also thinking, sir. That's why I placed another list in the plexus.
Enna Arul Selvan, Sivakumar, neenga enna solreenga?
Yeah, bilateral plexus involvement, I think bladder can get involved, sir, because ultimately the plexus is one which is supplying the bladder nerves also.
Avlo
So there is
significant
a
plexus involvement irukka, Siva?
bilateral plexus, sir. Bilateral, we usually don't come across bilateral plexus.
Exactly.
Usually
See,
unilateral.
it's not localized. See, Arul Selvan கேட்ட மாதிரி electrophysiologically, have we localized it to the plexus? நம்ம வந்து convenience sake, we are bringing in plexus. As you said, bilateral plexus involvement is unusual. And what are the conditions where you get bilateral plexus involvement? See, Hansen's 17% of cases plexus can be involved. Aduvum involve ஆகலாம். But in the bilateral plexus involvement significant extent varuma. And Arul கேட்ட மாதிரி, do we have electrophysiological studies to support a plexus involvement? Enna Arul Selvan?
Sir, obviously they had F responses, but she underplayed. She doesn't know the importance of F responses.
So we don't have information as of now. First of all, bilateral plexus involvement, how common? What is the etiology of bilateral plexus involvement? Usually, it's again related to some serum, related to post-surgical procedures, related to a demyelinating problem. So, how common is a Hansen producing bilateral plexus? Theoretically, pesalam, but how common is this?
So one is certain, sir, the patient has got diffuse involvement. Almost all the nerves in the lower limb is involved, including proximal nerves.
Yeah.
Random reflex is also lost.
Multiple peripheral nerves, now it's become confluent.
So we cannot differentiate between multiple peripheral nerves or plexus.
Absolutely.
Or radical. I think everything is involved diffusely.
Exactly. It's a proximal nerve roots are also involved, S1, S2, S3.
So we can't separately say it's a plexus involvement.
Definitely you can't say.
I mean, it's not an exclusive plexus problem. It's
No.
much more than that. Right? We have two more cases. Very good case, Pa. Very good case.
Thank you.
Sir, last one question. How would you explain the weight loss?
Weight loss occurs with any of the inflammatory lesions, illama. Hansen's weight loss. வரலாம்ல.
What about the appetite?
No, Abhirami said
Yes.
chronic infection சொன்னாங்க. This
Yes.
chronic infection which is not confined to one nerve. It is a multiple nerve involvement. So it's probably, I mean, within inverted commas, systemic involvement. We do not know other organs apathy. And other thing is inflammation, inflammation, contributing to weight loss. That's how I would think. In fact,
Weight loss.
Weight
Sorry,
loss.
appetite.
Appetite is reduced only, sir. Previously, now he can't able to eat as much before he can able to take.
That is due to the autonomic involvement of the gut.
But no postprandial fullness like symptoms or abnormal sweating like that. There is no, sir. But we can't exclude in total.
Right.
Thank you. We are getting late. We'll move on to the next presentation. Thanks. Excellent presentation, Abhirami.
Yes, sir. Thank you.
Very good. Good
Thanks.
cases.
Thank you.
We want the cases. We want. Okay.
Excellent.
Thank you.
Thank you.
Thank you, Shivakumar. Thank you, Thiruvananthalan. Thank you, Abhirami.
Yes, sir. Thank you.
Now we will move on to the next case. I'll again hand over to Professor Shivakumar. Sir, please carry on.
Yes, sir. Next case is presented by Sumitra.
Second case, innor Terla. Oh, Shashidhar.
Yes, sir. Right there. Yes, sir.
Sir, உங்க screen share பண்ணுங்க. Hello, anybody there?
Can the Sun people assist him? If he's not ready, can move on to the next case. Then we'll come back to this.
Sir, they are presenting all from the same room, sir. That I think there is a problem, and they will start soon, sir.
Okay. Net problem, huh?
That computer they are presenting from pad, sir. That pad is not working now. They'll start in few minutes.
Okay. No problem. Go ahead. Break. We'll take a break.
Now it's coming, sir. Now it's projecting.
Shashidhar, can you now present now? The problem is over now.
Now we can see your slides, Shashidhar.
The problem. The
audio is not coming properly. We can't hear you well. Shashidhar.
இல்லைன்னா இங்க கொண்டு வந்து போட சொல்லுங்க. இல்ல சரி.
Ready அங்க room போறோம். வேணாம்.
சரிங்களா?
சார் அவங்க ஃபைல் இதுல ட்ரான்ஸ்ஃபர் பண்ணுவாங்க.
அங்க room போறோம்.
Okay.
இல்ல அப்படி வராது.
Visible now.
Can you hear my voice, sir?
Yes, sir.
Yes, yes.
Yes. Sir, sorry for the delay, sir.
Yes,
So,
yes.
this case, 1 minute, ma'am. This case, you can go ahead with the findings. And then if we need, we'll discuss after the clinical findings also. Lena,
Okay,
straight
sir.
away proceed பண்ணலாம்.
Okay, sir.
Okay,
Yes,
sir.
sir.
நான் hearing. Hearing.
Yes, sir.
Hearing.
Today's second discussion. Mr. X is a 28 years male. His education status is 5th standard. He's a driver by occupation. He's a right-handed individual. He's a resident of Assam. His informant are patient and his wife, reliable. Presented with chief complaints of weakness of both lower limbs for 2 years duration, and weakness of both upper limbs for 1 year duration, and tremulousness of both upper limbs for 6 months duration. History of presenting illness. Patient was apparently normal 2 years back. Then he developed insidious onset weakness of left lower limb in the form of difficulty in gripping slippers, which is progressive in nature, and few weeks later, he had noticed difficulty in using left leg, like driving car while using clutch. After 1 to 2 months of noticing of his illness, he developed stiffness of left lower limb and had difficulty in climbing stairs and difficulty in getting up from squatting position. And over few days, he used to drag left lower limb while walking and needed assistance for walking. Around 3 to 4 months late, after onset of his illness, he developed urinary symptoms in the form of increase in frequency of urination, urgency, and later within few days, he had difficulty in initiating urination, and later developed unaware of passage of urine. 4 to 5 months later, after onset of his illness, he developed weakness in right lower limb in the form of difficulty in gripping slippers and difficulty in getting up from squatting position associated with the stiffness, and had difficulty in rolling over bed, and became bedbound within 6 months after onset of his illness. Around 1 to 2 months after becoming bedbound, patient developed weakness of both upper limbs in the form of difficulty in holding objects like spoon to eat, and difficulty in buttoning and unbuttoning shirt, which later progressed to difficulty in raising arms above the shoulder, and had difficulty in doing activities like combing. There is no history of difficulty in holding neck upright, no history of thinning and twitching of muscles. Patient also had sensory complaints in the form of decreased perception of sensation of clothes below waist, and had a band-like sensation around waist, noticed along with weakness of lower limbs, but was able to differentiate hot and cold sensation while cleaning his body, and able to perceive pain sensation like insect bite. There is no history of neck pain or low back pain or electric shock-like sensation on bending neck. Around 1 year of onset of his illness, patient developed tremulousness of both hands on reaching objects, not present during at rest. There is history of tremulousness of head noted for past 6 months. There is no history of altered sensorium, no behavioral changes, and no memory disturbances. Is patient able to smell well? No history of defect in vision, double vision, or drooping of eyelids. No history of abnormal sensation over face, no difficulty in opening, closing, and side-to-side movements of jaw, no history of deviation of angle of mouth, no difficulty in closing eyes, no history of hearing impairment, no history of swallowing difficulty or regurgitation of food particles, no history of difficulty in turning head sideways and shrugging of shoulders, no history of deviation of tongue, no history of fever, weight loss, no history of joint pain, skin rash, or trauma. In past history, no history of diabetes, hypertension, tuberculosis, or seizure. No history of previous hospitalization. Personal history, he consumes both vegetarian and non-vegetarian diet. Sleep is normal. He used to consume whiskey 1 to 2 quarters per day, weekly 2 to 3 times for about 10 years, and stopped drinking after starting of his illness for 2 years. He's a smoker, consumes 4 to 5 cigarettes per day for 10 years. He's married 11 years ago and had son of 10 years of age. A birth history, he is born out of non-consanguineous marriage. There is no history of delay in attaining milestones. Family history, he had 4 brothers and 3 sisters, and no history of a similar illness in family members. Clinical progression of symptoms. Initially, he started in around Jan 2024. He had left lower limb distal weakness, followed by proximal weakness associated with stiffness. Then he developed urinary symptoms in April 2024. Later, in June 2024, he developed right lower limb distal weakness, followed by proximal weakness and truncal weakness associated with the sensory complaints of decreased touch below waist. In August 2024, he noticed weakness of both upper limbs in the form of distal, followed by proximal weakness. Later, after 1 year of onset of his illness, in Jan 2025, he has noticed tremulousness of upper limbs on reaching objects. In June 2025, he has developed a tremulousness of head. Summary: 28-year male presented with insidious onset progressive neurological illness of 2 years duration in the sequential order of asymmetric onset left lower limb distal weakness, progressed proximally and associated with stiffness of left limb. And then he developed spastic type of bladder involvement in the form of increased frequency and inability to urinate micturition and unaware of passage of urine. Then he developed a right lower limb weakness, distal followed by proximal and associated with sensory involvement in the form of decreased touch sensation and band-like sensation below waist, and had weakness progress to truncal muscles. Upper limb weakness, later he developed distal followed by proximal without any wasting or fasciculations or diurnal variation. Then he developed tremulousness of both upper limbs and head tremors, and the symptoms were static for the past 6 months duration. Structures involved are bilateral pyramidal tracts above C5 level, and sensory involvement in the form of posterior column tract, form of decreased touch sensation and band-like sensation below waist L1 level, and Yeoman type of bladder, it is above sacral center, and tremulousness of head and limbs. I would like to consider either it could be cerebellar or extrapyramidal, which I will confirm after examination. Differential diagnosis at this point, I was thinking of slow growing tumors, space occupying lesions around CV junction. And next DD I would like to consider is demyelination. And third DD I would like to consider infections, like chronic infections like HIV. And because of his chronic alcohol background and decreased nutrition intake, I would like to consider a subacute combined degeneration. And lastly, I would like to consider degenerative causes like leukodystrophy, HSP plus, and spinocerebellar ataxia.
See,
So,
1 minute. This is
yes,
where you will have to discuss whether this is an intramedullary or an extramedullary lesion, as Arul Selvan asked in the previous case.
yes, sir. So because of the early involvement of bladder and asymmetrical presentation, I would like to consider a intramedullary lesion, sir.
Exactly. So some of these which you are put up here,
Yes, sir.
does it come up with intramedullary lesion?
Uh,
A differential diagnosis.
no, sir.
So that's why that becomes important. Analysis
Yes.
like that, you will have to say this is an intramedullary lesion, because if it's an intramedullary lesion, what would be your differential diagnosis?
Intramedullary, I would like to
Arul, you
consider.
can take over, Arul. Sorry, I intervene.
No, sir. Okay, sir. Yeah, I just want you to get. Yeah, please go ahead, sir.
Right. Intramedullary, it could be first DD because it is a slowly progressing of its symptoms for few years duration, sir. So first DD, I would like to consider like a space occupying lesion, intramedullary, sir. Then there is second DD, as the symptoms are progressive in a young age, I would like to consider demyelination, sir.
What demyelination?
Like primary demyelination, like primary progressive multiple sclerosis can be
Okay.
one of the TD.
Arul is asking her question.
Is it spinal cord or are you thinking central nervous system, brain?
Above C5 high cervical and above lesion, I am thinking, sir.
Right.
Because symptoms are progressive with the tremulousness and of hands on reaching objects and head tremors are there. The lesion is progressing, sir.
Dr. Reddy, the question was, you said MS. So is it a spinal MS or is it a cerebrospinal MS? That's what Arul was asking.
First, spinal MS only I am considering, sir.
You said the tremulousness could be due to cerebellum or
It is progressing, sir. So both spinal plus with cerebral involvement also, sir.
Okay, any other differentials?
Reddy, you have presented a very good history. So
Yes,
your
sir.
history is favoring intramedullary spinal cord lesion.
Yes, sir.
So it's a straightforward case, but the interesting one is the tremor, isn't it? You mentioned about the head tremor and neck tremor. Sorry, upper limb
Yes,
tremor.
sir. Yes, sir.
Tell me the possibilities for this myelopathy with the head tremor, upper limb tremor. It may be extrapyramidal or it may be cerebellar.
Yes, sir. Cerebellar 1DD will be like he's an alcoholic, sir. Degeneration of cerebellar white matter tracts. So because of that, also he could be developing tremulousness on reaching objects.
Right? Or any other neurodegenerative causes?
Neurodegenerative, like one of the DD I brought is like a spinocerebellar ataxia, sir. But in this case, no family history is not there, sir. And predominantly pyramidal symptoms first, later only he has developed a tremulousness of
but it was
upper
asymmetric.
limbs. Asymmetry is there, sir. One of the against points.
Later, then it progressed to the right leg and then come to the upper limb. So it was a
Yes, sir.
it's less likely to be hereditary neuropathy or hereditary ataxia syndrome because it started asymmetrically.
Yes, sir.
Or any possibility of CV junction anomaly junction?
Yes, sir. First thing I have kept as a CV junction only, sir. Because of the intramedullary involvement, I would like to consider like a space occupying lesion, sir.
Can a CV junction anomaly produce intramedullary involvement? What sort of CV junction produces intramedullary involvement?
SOL, sir. CV junction usually
This is
will...
extramedullary. Extramedullary.
Yeah, you
CV
said
junction means extramedullary.
CV junction lesion, probably extramedullary involving the spinocerebellar tracts.
Yes, sir.
there is a possibility of hereditary malformation with syringomyelia. So they can have both extramedullary and intramedullary.
Yes.
Okay.
Syrinx is one thing we consider.
Syrinx, but there is history-wise, there is no history of dissociated sensory loss is not there, sir. So
okay. That we have to confirm with the examination.
We have to confirm with the yes, sir.
Sir, 1 minute, sir. The problem with this patient is that patient first developed a lower limb symptom, sir.
Right.
Then followed by bladder, then upper limb, then lower limb. Again, lateral only upper limb develop. So if there is an intramedullary lesion, the patient should develop upper limb fiber involvement first. If you think of an intramedullary lesion, because the pyramidal fibers are medial most in the corticospinal tract.
That's correct,
so
sir.
Patient develop lower limb, then that probably is extramedullary also we have to think of. Bilateral lower limb only develop, the bilateral outer fibers are involved in addition to bladder. So we have to put a lesion compression at bladder as well as lateral part of the corticospinal tract. This is unusual, which cannot be explained with intramedullary, extramedullary concepts.
The intramedullary came in because the early bladder involvement.
Otherwise, should have been involved, sir. Because if we think about intramedullary involvement, then upper limb should have been involved earlier than lower limb.
Yeah, we have one for intramedullary, other for extramedullary. One history suggestive of intramedullary, other history, as you pointed out, looks like an extramedullary. So can there be a combination?
Combination of extramedullary and intramedullary. Usually we see in the CV type lesions.
That's what Arun had already pointed out.
Can we proceed with the examination, sir?
Yes, please. Of
Yes.
course.
Yes.
Correct. This time.
Some of the points I've kept for points for and against, sir.
We'll come back to this later after you present.
Okay. Yes. General physical examination. Patient is moderately built and poorly nourished. Vitals are blood pressure 124/70 millimeter mercury, right upper limb supine position. Pulse rate is 72 beats per minute, normal in volume, regular, and all peripheral pulses felt. Respiratory
You can
rate
go
is
to the next
14.
slide. You can go to
Yes.
slide. General physical examination, nothing now abnormal.
Yes.
And mental
CNS
function also normal.
examinations.
Yeah,
Yes.
next you can go to next.
Cranial nerves examination is also normal, sir.
Yeah, next.
Spinomotor system is bulk is generalized.
One thing, Siva.
Yes.
Did you say anything about the 12th now? Did you examine the wasting of the tongue and passage?
It is not there, sir. Tongue power is normal. Movements is normal. No fasciculations or fibrillations.
Okay, thank you. Because platyphasia we have an invasion of the.
Yes, lower cranial nerves are not involved, sir.
Okay, thank you. Sorry to interrupt.
And spinomotor system, bulk generalized wasting is seen, sir. Upper limb right side 1 centimeter difference in measurement is there, sir, both in arm and forearm. And lower limbs symmetrical measurements are there, sir. And tone upper limbs it is normal, and lower limbs bilateral spasticity is present, sir. Power examination, shoulder joint flexion bilateral it is 4, sir. Extension, adduction, abduction is 3, sir. Elbow joint flexion is 4 and extension is 3. Wrist joint flexion is 4 and extension is 3, sir. Hand grip is around the right side 70% and the left side 80%. And lower limb power examination, both bilateral hip, knee and ankle, 0 power is there, sir. Superficial reflexes, conjunctival, corneal, palatal, gag, and abdomen cremastic. Gag reflex intact. Abdomen cremastic reflex is absent. Anal reflex present, and bilateral plantar extensor. Deep tendon reflexes, jaw jerk is not elicitable, sir. Bilateral biceps supinator and triceps is 3+ exaggerated. And knee reflexes, right side 3+ and left side patellar clonus is there, and bilateral ankle clonus, sustained clonus is present, sir. And primitive reflexes, snout, sucking reflex, palmomental, and grasp reflex are absent, sir. The video showing reflexes. There is exaggerated bilateral knee reflex by both sides. Ankle reflex also this. Left side ankle also this. And there is left sustained clonus is present. And patellar clonus is also there. Right side also sustained clonus is present. Exaggerated supinator there. Exaggerated biceps and triceps. Exaggerated left upper limb reflexes. There, here we can see head tremors and jaw jerk is not elicitable. Sensory system examination, spinothalamic tract, both pain and temperature are normal. Posterior column sensation, decreased fine touch is seen below L1, and vibration sense is impaired below D10 level, and joint position sense is impaired in both sides, lower limbs. Cerebellum examination, titubation is present, nystagmus is absent, speech is a staccato type of speech, and finger nose incoordination is present, and dysdynocasia is present. Bilateral intention tremors are present, and lower limbs and rhombox could not be tested. So, video demonstrating cerebellar features. Here, head titubation is seen. Sir. Intention tremor is seen. Left side also intention tremors are noted. Extraocular movements are normal. Circuits are normal, pursuits are normal. नाम क्या है? किधर से आए आप? Extrapyramidal system, there is no rigidity or abnormal posturing of the limbs. Autonomic nervous system examination, there is no resting tachycardia. Spine and cranium is normal, no gibbous or no spine tenderness, and there are no meningeal signs. Other system examination, RS bilateral air entry is equal and no added sounds. CVS S1 S2 head normally. For abdomen is soft, non-tender, and no organomegaly. Summary, examination findings, 28 years male, presented with chronic progressive neurological illness with spastic weakness of bilateral lower limbs with power 0/5 and bilateral upper limbs power 3/5 and hyperreflexia of all four limbs with bilateral plantar extensor and a sensory involvement of posterior column with a decreased vibration below D10 level and cerebellar involvement with head titubation, bilateral intention tremors, staccato speech present with normal higher mental function, cranial nerves, and without any extrapyramidal involvement. Shall I proceed, sir?
So your differential diagnosis at this stage?
With the clinical examination, I have confirmed whatever history he has. That extra thing, I am ruling out extrapyramidal, sir. Cerebellum, I am involving, sir, in structures included.
Does your differential now?
Differential.
Does no,
Yes,
no.
sir.
Does your differential now includes non-compressive myelopathy, or you will still sustain with a compressive myelopathy?
There is no, other than that, the sensory examination, there is no definite level can be seen, sir. So non-compressive, I'm going in favor
No,
of.
first in the discussion, we said it's likely to be an intramedullary lesion, right?
Yes, sir. Yes, sir.
One red flag was that it does not typically fit into the intramedullary because both lower limbs were involved and only then the upper limbs.
Yes, sir.
Right. So
yes, sir.
the other alternate, now we find that he has a cord signs. He
Yes,
has
sir.
cerebellar involvement.
Yes, sir.
So cord and cerebellar involvement can happen with a high cervical pathology
Yes,
if it
sir.
were to be a compressive lesion.
Yes, sir.
My question is, would you bring in a non-compressive consideration also now? Non-compressive myelopathy with
Yes, sir.
cerebellar involvement.
Yes, sir. Upper level and definite level is not seen, sir. So non-compressive, I'm bringing in, sir.
If so, if you think non-compressive with cerebellar, what would you consider? What would be your...
Demyelination is still possible, sir.
Quite right. Yes, we would certainly consider multiple sclerosis.
Yes, sir. And infection also still we can keep the possibility.
Yes. What infections?
Chronic infections like either tuberculosis or HIV, sir. But with this long duration...
No, HIV is okay. Where do you think is the tuberculosis?
Tuberculosis less likely, sir, without any other constitutional symptoms.
No need to mention it. HIV, yes, of course, HIV can produce anything.
Yes.
So now the question is, do you think first, is it a
First,
non-compressive myelopathy, or do you think compressive intramedullary lesion with cerebellar? See now, or a high cervical lesion, compressive lesion.
Non-high cervical with cerebellar involvement, sir, and no definite level, so non-compressive lesions like demyelination and infections are my DDs at present, sir.
Arul, you take over. I'm sorry, I'm intervening.
If it is the demyelination,
Yes.
what type of demyelination you are favoring? Is it some multiple sclerosis or MOGAD or NMO?
It's a progressive lesion. Oh, sorry.
It is.
It's a progressive lesion. It's not a stepwise lesion. It's not multiple lesions. So progressive lesions, which one of the three you will consider?
SAR is giving you a clue. It's not relapsing and remitting. It's not coming and going.
Sashidhar, are you there? I think we lost him.
Shashidhar?
Hello.
Sivakumar? Sashi irkara?
Shashi, he is in a different room, sir. Just go check it. No, Shashi is in Varda. Fine. You can talk to. Case is already over. You can talk to them. Yeah, you can discuss with them.
The question was which one of a demyelinating lesion it is. Whether is it MS, is it MOGAD, is it NMSD? That's what allegations are asked.
So there is like not a classical picture like without any other thing like optic neuritis or brainstem involvement is there. So MS, I would like to
Common
keep
for all
first.
of these. That is common for all of these. So then
Yes,
the question which I gave you was, this is a progressive lesion.
Yes.
So which one is a progressive lesion?
The MS is a primary progressive. MS could be my first DD.
That should be the answer.
Yes.
But in practically, the cerebellar lesion is quite rare in MS, isn't it, sir?
No
Allegation,
Professor, allegation. Cerebellar lesions are not rare, not
This
uncommon.
type of pan-cerebellar?
Yes, sir. It can happen depending
In
upon.
fact, the prognosis is worse in such cases where cerebellar is involved.
You can have a demyelinating plaque in the cerebellar peduncle, either middle or lower cerebellar peduncle, they can have a significant lesion. We've seen many patients with the cerebellar syndromes. That's not uncommon, sir.
Okay.
And the prognosis is not good in those cerebellar lesions. As a distinction. Right. Continue, ma. Sashi, continue.
Are you ready now?
Are we going with investigations?
Go ahead. என்ன நமக்கு வேணும் MRI தான் first வேணும். What is the MRI source, Sashi?
I think he is adjusting his laptop.
There is slide he can tell us, no? What did the MRI show?
To be ready, sir. Findings.
I think he is an alcoholic.
Yes, he is.
Hello, sir.
Any alcohol related?
நிறைய பேர் alcoholic தான். போன கேஸும்
Hello, sir.
alcoholic தான்.
Can you hear that?
Yes. Many times alcohol becomes a red herring. Yes, Sashi, we are waiting for you.
Sir, but he has the reflexes are very brisk. Ankle jack is also brisk, so we cannot have a subachial degeneration of spinal. இந்த alcoholic cerebellar syndrome.
லோனஸே இருக்கு.
Bonus here, sir. There is a strong myelopathy component.
ஆங்கல்ல எக்ஸ்க்ளூசிவ் மயலோபதி மாதிரி தான் இருக்கு. மயலோபதி வித் செரபெல்லம். Myelopathy ataxia or ataxia. Sashi, you just tell us the MRI findings, Sashi. சிவா எம்ஆர்ஐல என்ன இருந்தது சிவா?
சிவா காணும்.
அவரும் இல்ல.
சிவாவும் அங்க போயிட்டாரு இல்ல.
ஓகே ஓகே. டு ஹெல்ப் them.
Hello.
Yes.
Hello. Hello.
Yes, please. Go ahead. Go ahead.
சிவா சார் கேக்குது.
Hello.
கேக்குது சார்.
உங்க வீடியோவும் வருது. வீடியோவும் வருது.
Sir, MRI coming.
Sorry for the disturbance, sir.
It's okay.
Coming to investigation, sir. It's basic blood counts like
MRI மோல சொல்லுப்பா, அப்புறமா இதுக்கு போலாம்.
Yes. MRI, there is a T2 sagittal section. CV junction, it is normal, sir, except that there is a loss of lordosis, sir.
Okay.
And there is a thinning of cord is noted from D1 to D9 level, sir. Thinning of the cord. Other than that, rest of the spine is looks normal, sir.
Contrast?
Contrast, there is no enhancement, sir.
Right. Okay.
Brain? You showed some brain.
Yes. Brain post-contrast imaging, T1 images are normal, sir. And DWI, there is a hyperintensity in posterior limb of internal capsule and splenium of corpus callosum. There is a hyperintensity.
Splenium is.
Splenium of corpus callosum, hyperintensity is there, sir.
Right.
And even in the cerebellum, there is a dentate nucleus, a hyperintensity is seen, sir.
So impression?
Tracks are hyperintensive seen, sir. Mainly in the posterior limb of internal capsule.
Yeah.
And other than that, splenium of corpus callosum and dentate nucleus hyperintensity is seen, sir. Cord, there is no intramedullary or extramedullary lesion is not there, sir. No
So
compression, no mass is seen.
Radiologist impression?
Sir, there is another nerve conduction also has been done, sir.
Okay.
Nerve conduction, motor nerve conduction, right peroneal is not obtained, sir.
Can you zoom up, please? Can you zoom up? We'll see the values.
Yes.
Please go ahead. Yeah.
Motor nerve conduction studies, bilateral, medial, ulnar, and normal, sir. Lower limbs, right peroneal is not obtainable, sir. And left peroneal obtained, sir. And bilateral tibial, it is normal. Only one side it is not obtained, sir, right peroneal. And sensory nerve conduction studies, upper limbs bilateral radial, bilateral ulnar velocities are reduced, sir. Other rest of the thing is just normal, sir.
How about the optic nerves?
VEP done, it is normal, sir. Clinically also, there is no RAPD, sir. 300 latency was in normal range.
Okay, okay.
Radiological differential diagnosis, can you tell us?
What was their impression? Radiologist impression.
Radiologists here, they have reported as MND, sir. But only exclusively that a red glass wine sign with hyperintensities of the corticospinal tracts is in this picture. It is seen, sir, like a red glass wine sign. It is called, sir, bilateral hyperintensity.
Hourglass sign. Okay.
Yes, sir.
In other words, the pyramidal tract is outlined. That's
yes,
what
sir.
Yeah.
Yes, sir.
But the splenium of corpus callosal involvement?
And the
cytotoxic lesions.
No, that's one sign which is not specific. Yeah, you do see that pyramidal tract is degenerated, right? But what about the other findings?
Dentate nucleus hyperintensities are seen, sir.
So now you give your impression. That was the radiologist's impression. Doesn't matter. Now taking everything into consideration, the thinning of the cord is also there. That also you will have to consider. Yes.
Yes, sir.
So what
DD
is your...
is now degenerative, we can think, sir, with the cord atrophy.
Yeah, what degenerative disorder?
Leukodystrophy and HSP plus can be thought of, sir, at present.
Right. Yeah. Okay. Right. That's why I initially asked non-compressive NR counter. We were taken by the bladder involvement, early bladder involvement. Okay. So you think it's a leukodystrophy or a HSP?
Yes, sir.
So you proceed with genetic study?
Yes, sir. Genetics, yes. Genetic study, it came out to be ABCD1 gene mutation, sir, suggestive of adrenoleukodystrophy, sir, which is X-linked recessive.
Very good.
Excellent.
Yes, comments?
Sir, we agree, but there is a bladder involvement, isn't it? How could you explain the bladder involvement?
We are getting to learn more and more, Arul. Once we get see the phenotypes keeps changing.
Yeah.
What we conventionally thought is no more valid. That's what it looks like. It's for discussion, yes, initial discussion, that is what we would consider. Still, it is valid for exam purpose and discussion. But now with the findings which we find, phenotypes keep changing.
That's true. We can agree that it looks like a white matter disorder, non-compressive, progressive, but it is presented with the asymmetrical. Left leg first involved.
History தானே எவ்வளவு தூரம் history depend பண்ண முடியும். அது அடுத்தது.
Sashidhar, how we are going to treat this patient?
For adrenoleukodystrophy, early onset.
Did you check for the adrenal function? Did you check for the adrenal function? Serum cortisol?
Cortisol level we didn't do, sir, but his electrolytes were BP is normal, sir.
You can do it in GH. Serum 8 AM cortisol, they will do it, isn't it? Simple test. It's not that.
We didn't think of, sir, until this genetic thing has come.
Correct. Genetic studies are throwing up surprises.
So how we are going to treat them?
Treatment, there are no medications for this at present, sir.
Stem cell irka?
We heard about Lawrence oil. Sashidhar.
They are giving, sir, for adult onset leukodystrophy treatment. I'm not aware.
Right, okay. Thank you. So can we move on to the next case, sir?
Yes, sir.
For the discussion, because it's
stem cell transplant
as per childhood onset, infantile or childhood onset suggested, sir, not for
Yeah,
adult.
what happens in an adult? How is it different? It may not be that effect. Okay, right. Anyway, we do not know. Right. Continue with the next case.
Okay. Thank you, sir.
Good
Sir,
case, sir. Ready, sir? Good case.
Yes, sir. Thank you, sir.
Once again, you, Shivakumar, and through our children, yes.
well
We are
presented.
more and
Thank
more
you, sir.
material.
Shiva sir, can we move on to the
Yeah.
next case? Because
Yes, sir, I can move. I think they are ready, sir. I'll just ask them to. Ma, can you just proceed now?
இவரு ஒன்றும் அடிஷன் ஃபீச்சர் இல்ல சிவா.
கிளினிக்கலா ஒன்றும் இல்லை சார்.
எந்த கேஸ் சார்?
இந்த கேஸ் தான் ADLD.
இல்ல ஒன்றும் இல்லை சார். Only after the genetic study came only then we were surprised.
ஓகே. ஆனா கிளினிக்கலா ஒன்றும் பார்த்ததுக்கு ஒன்றும் அடிஷன்ஸ் ஃபீச்சர்ஸ் இல்ல.
இல்ல சார், ஒன்றும் இல்லை. Could not suspect anything.
Right. அருள்சலன் VLSC இது செக் பண்ண முடியுமா? அருள்
அரைல் சல்பேட்
இல்ல லாங் செயின் ஃபேட்டி ஆசிட் செக் பண்ண முடியுமா? We have the facility.
எஸ் சார், வி ஹேவ் இந்த மாலிகுலர் மெடிசன் ஹைதராபாத்ல பண்ணி கொடுக்குறாங்க. பட்
CCMT சென்டர் ஃபார்
எக்ஸலன்ஸ் ஆஃப் மாலிகுலர்
CCMT னோ ஏதோ சொல்லுவாங்க, அது மாலிகுலர் டெக்னாலஜி CCMT
இதுல
ஹைதராபாத்.
பண்றாங்க.
அங்க அனுப்பலாம் சிவகுமார். CCMT they you do it free of cost.
சிவா லைன்ல இல்ல சார்.
Right. So அடுத்த கேஸ். Yes, Dr. Sumitra, go ahead.
Sir, Vijayan, 1 minute.
Sir, please, yeah.
The so-called inverted wine sign, sir. Long back, 25 years back, the so-called inverted wine glass sign, sir.
ஆமா.
25 years back, KG Srinivasan in Madurai had described it. He called it the Namam sign.
என்ன சைன்?
நாமம் sign.
நாமமா? அவர் கிளாஸ் சைன் சொல்லுவோம், அதுவும் ஒண்ணு. ரைட். கரெக்ட். நாம மாதிரி தான் இருக்கும் அவர் கிளாஸ்.
ஆமா சார். இது வந்து he described it more than 20.
CMT ல சொல்லுவோம்ல.
ஆமா சார். 25 years back when I was doing DM, he taught me.
Talk about Mary Tooths.
KG இல்ல, இந்த இதுல சார் MRI ல.
Right. MRI, right.
And the MRI finding was described initially by KG Srinivasan long back, sir, in Madurai.
Excellent.
Right.
Radiologist.
ஆமா. என்னன்னு சொல்லுவாரு அவரு?
நாமம் சைன் சொல்லுவார் சார். அது வந்தாலே MND எழுதிடுவார்.
Okay.
When we used to, as students, when we used to present cases to him, he used to teach us. Just one addition.
Very good, Vijay. Thank you.
Thank you.
Sumitra, can you present, please? We cannot able to hear you, madam.
Audio is not working.
Yes, sir. My case is.
Now you are audible. Yeah, go ahead. Can you start again?
Yes, sir. Yes, sir. Good morning, sir. My case is a 68-year-old gentleman coming from Salem, right-handed individual, studied up to 9th standard, working as a marriage mediator, informant, patient and his wife, which is reliable. Chief complaints, numbness and weakness of both hands for past 1.5 months. History of presenting illness, patient was apparently normal until 1.5 months back. Then he began to feel an electric shock-like sensation in both hands while touching the water for brushing his teeth in the morning. On next day, he felt numbness and decreased sensation, following which unaware slippage of objects from both hands, but able to perceive hot and cold sensation and pain in both hands. associated with weakness of both upper limbs, symmetrical onset in the form of difficulty in mixing food, buttoning and unbuttoning shirt, difficulty in holding objects, difficulty in taking food to mouth over a week time, able to raise arm above his head and able to comb hair. He also noticed thinning of both hands and arm, along with the difficulty in getting up from sitting to standing position without support. Also difficulty in climbing up and down stairs over a period of time. Able to hold slippers without slippage and insinuating feet into chappals. Able to turn side to side in bed, raise a head off from pillow. No tightness and flyness of limbs. No twitching of muscles. No diurnal variation. Able to perceive cloth sensation over the entire body. Able to differentiate hot and cold sensation of water over the body while taking bath. Able to perceive insect bites. Able to feel the floor normally on walking. Able to negotiate narrow pathway. Able to walk in dark. Does face wash without unsteadiness. No electric shock like sensation while bending neck forward. No radiating pain. No band-like sensation. Able to feel bladder fullness, feel passage of urine, able to hold and void urine, no constipation, no history of dizziness while getting up from bed, no sweating, no palpitation, no altered behavior, forgetfulness, wayfinding difficulty, and identifying relatives and hallucination, no delusion. Able to smell well, see in all direction, able to appreciate colors, no double vision or drooping of eyelids, able to feel facial sensation, chew well, no facial asymmetry, able to hear, no tinnitus or vertigo, swallow food, able to struggle his both shoulders and muscle food well. No slurring of speech, no clumsiness in hand on reaching objects, no unsteadiness while walking, no history of slowness of activity, no abnormal movement or posture, no history of LOC, no seizure, headache, blurring of vision, no history of fever, neck pain, stiffness of neck, no history of fall from height and lifting heavy weight on overhead, no rash, no joint pain, no oral or genital ulcers, no history of chest pain, palpitation, breathing difficulty, abdominal pain, passing dark color urine, no loss of appetite, no loss of weight, and no chronic diarrhea. Past history, no history of similar illness in the past, had fracture in right arm following RTA in 2017. Known coronary artery disease since 2008. Not a known case of diabetes, hypertension, tuberculosis, asthma, epilepsy, cerebrovascular disease, thyroid illness. No toxin exposure, no chronic drug intake and native drug intake. Personal history, married, having 2 children, consumes both a vegetarian and non-vegetarian diet, normal sleep and appetite, no history of any high-risk sexual behavior, no substance abuse, not a smoker and alcoholic. Family history, nil significant. Summary, 68 years old male with coronary artery disease on medication presented with subacute onset progressive neurological illness in the form of dysesthesia as evidenced by electric shock like sensation, numbness in the form of decreased touch perception along with unnoticed slippage of objects in both hands, which was for past 1.5 months. Distal more than proximal weakness of upper limbs associated with thinning of hand muscles. Subsequently followed by proximal lower limb weakness within a period of 1 month, not associated with distal limb weakness, and which was not associated with cognitive impairment, cranial no, cerebellar, extrapyramidal, autonomic, and meningeal involvement. Shall I proceed, sir?
Continue.
Structures involved are peripheral nerves and cervical and lumbosacral roads. Possible diagnoses are subacute inflammatory polyradiculoneuropathy, nutritional polyradiculoneuropathy, metabolic, neoplastic, lymphoma, paraneoplastic, and infective HIV. General examination, patient was conscious, oriented to time, place, and person. Who was sedentulous, no pallor, no ectric, no cyanosis, clubbing, generalized lymphadenopathy, no pedal edema, no neurocutaneous marker, no markers for nutritional deficiency, no thyroid swelling, no joint pain, no rash and joint swelling, no thickening of peripheral nerves. Vitals were pulse rate 88 beats per minute, regular, normal in volume and character, felt all peripheral pulse normally. Blood pressure 130/90 millimeter mercury in left upper limb in supine position, and in standing position 140/90 after 3 minutes, no postural drop. Respiratory rate is 16 per minute, regular abdominothoracic. And bilateral carotid felt normal. Height and neck ratio 11.5, which was normal. Higher mental function, conscious, oriented to time, place, person, groomed well, speech normal, memory for normal for immediate, reason and remote, sleep good, no hallucination and no delusion, no emotional lability. My mini mental score was 25/30. Cranial nerve, there is no cranial nerve abnormalities on examination. Shall I continue?
Go ahead.
Next.
Go ahead. Yeah, go ahead.
Examination of spinometer system, bulk on inspection and palpation in both upper limbs, wasting of deltoid, triceps, pectoralis, supra and infraspinatus, flexors of forearm, and bilateral first dorsal intarsi and right thenar muscle. In lower limbs, asymmetrical wasting of medial aspect and lower third of leg muscles, left more than right. First dorsal intarsi and deltoid, pectoralis, deltoid, and flexors of forearm, and asymmetrical wasting of leg.
No fasciculations.
No fasciculations.
Right.
And intensics of foot. Examination of spinomotor system. Bulk measurements. There was a asymmetrical difference in right upper limb 1 centimeter difference, lower limb in thigh 2 centimeter, in legs 1 centimeter. Tone for all 4 limbs normal. Neck muscle power, neck muscle flexion 4/5, extension 4/5, shoulder flexion extension 5/5, abduction 4/5, adduction 4/5, elbow flexion extension 4/5 in both upper limbs. Wrist flexion 3/5, extension 3/5. In left upper limb, wrist extension 4/5. Hand grip 60% in right, left 70 to 80%. Hand muscle power, thenar muscles, hypothenar muscles, lumbricals, palmar and dorsal intarsi, finger flexors and extensors are weak. Lower limb, in a hip, flexion 4/5, extension 3/5, abduction 3/5, adduction 4/5. And internal rotation, external rotation 3/5. Knee flexion and extension 4/5. Ankle dorsiflexion 5/5. Plantar flexion 4/5. And toe flexor and toe extensors are weak. Reflexes, corneal conjunctival reflex present, palatal pharyngeal reflex present, abdominal reflex absent, cremasteric absent, plantar flexors in both sides, deep pendant reflex absent. No frontal release sign. Sensory system, touch decreased, fine touch decreased in palmar and dorsal aspect of hands up to wrist in both hands. Pain normal, temperature normal in both hands. Joint sense, upper limb impaired in both upper limb and normal in both lower limbs. Vibration sense normal in both upper limb and impaired in both lower limb and up to T6 spinal level. Rhombus test is negative. Test for coordination, finger nose test and finger nose test. There was clumsiness present in eye closed state. Heel knee test able to do normally. Tandem walking normal, gait normal. No involuntary movement, no abnormal posture and bradykinesia, no resting tachycardia, abnormal sweating, no postural fall in BP. Spine and cranium normal. No signs of meningeal irritation. Other system examination normal.
Summary.
The examinations. Summary, 68-year-old male, non-CAD patient presented with a subacute onset progressive neurological illness for past 1.5 months in the form of sensory impairment manifested as dysesthesia, loss of position sense, loss of position sense and normal vibration sense in both upper limb, and normal position sense and impaired vibration sense in both lower limb, and spine up to T6 level. with a negative rhombus test. Asymmetrical wasting with a distal more than proximal weakness of both upper limb and a proximal more than distal weakness of both lower limb and neck muscle weakness with absent superficial and deep pendant reflexes without autonomic and cognitive cranial nerve, cerebellar, extrapyramidal and meningeal involvement. Structures involved are peripheral nerves and bilateral cervical and lumbosacral radicals, plus or minus posterior column of cervical cord. Differential diagnosis: inflammatory CDP, nutritional vitamin B12 deficiency, paraneoplastic neuropathy, and immune-mediated myeloradiculoneuropathy, paraproteinemias, metabolic diabetic, and infective HIV.
Wait a minute. What is the highlight of this presentation?
Sir,
What do you think is important?
dissociation of vibration and position sensing, sir.
Where? In the upper limbs?
Upper limb position sense is impaired, sir. Vibration normal. In lower limb, vibration is impaired. Position sense is normal.
Okay. What else is unusual? Not unusual, significant.
Sir, this type of presentation we have not yet came through.
Sorry?
This, sir, this dissociation must be.
No. Apart from that, what else is significant?
Apart from this peripheral.
No, madam. Significant wasting of the proximal muscle.
Asymmetrical wasting was this, sir.
Proximal.
Proximal and distal also.
Distal is in peripheral neuropathy, but the proximal muscles you had a significant wasting.
Yes, sir.
And another feature is it started in upper limbs.
Yeah.
Yes,
And
sir.
went on to involve the lower limbs.
That's true.
Yes, sir.
That is another feature of it, which we need to give significance.
Yes, sir.
So what do you think?
Sir, with symptoms started from distal upper limb, that too sensory, associated with weakness in the upper limb, distal more than proximal, in lower limb proximal more than distal. So I would think.
No. Wait. That was sensory. The
Yes,
motor,
sir.
as Arul pointed out, significant motor involvement in the upper limbs with wasting.
Yes, sir.
So it's not only a sensory neuropathy.
Yes, sir.
If you think it's a neuropathy, it's a sensory motor neuropathy, motor more than sensory, starting in the upper limbs and then going on to involve the lower limbs, which is predominantly distal. Am I right?
That's correct.
Lower limb predominantly proximal, sir.
What motor is proximal? Huh? Lower limb?
Yes, sir. In lower limb.
Okay,
Upper
okay.
limb, distal, only the predominant features.
Okay. So how would you discuss?
So both peripheral nerves and root, I would think, sir. Cervical and lumbosacral polyradicals, sir. So polyradicular neuropathy, both sensory and motor.
Arul,
I would rule out.
do we involve the nerves or only radiculopathy, Arul?
So tell us a neuropathy which starts in the upper limbs. It's extremely rare starting the peripheral neuropathy in the upper limb, isn't it?
Yes, sir.
Tell us a neuropathy which starts in the upper limb. Some inflammatory neuropathy.
Inflammatory and also nutritional and metabolic, like a B12 deficiency will start with upper limb, sir.
Is it?
Yes, sir.
Upper limb
Sensory
neuropathy.
symptom will start from upper limb. Is the predominant initial finding in B12 deficiency, sir.
That's not true. You start in the lower limb, it starts in the legs, then in the ascends up and.
Sir, sensory attacks is predominant in lower limb, but paresthesia may start from upper limb, sir. Upper limb distal.
Okay, tell me the CADP which starts in the upper limb. There are specific names for that.
Sir, Hirayama.
Hirayama?
No, sir. Polyradicular neuropathy. ಇಲ್ಲ sir. Polyradicular neuropathy causes upper limb predominant cause சொல்லிட்டேங்க sir.
He is asking which CADP starts in the upper limb.
We heard about MATSAM.
Bibrachial variant.
Is it?
The Guillain-Barré syndrome.
MATSAM.
Yeah, multifocal acquired sensory motor demyelinating neuropathy, which starts predominantly upper limb. That's called MATSAM.
Yes, sir.
ஏதாவது காமா சரி.
She put the paraproteinemia, so she's not.
Paraproteinemia ஏதாவது வருமா? Upper limb first. வேற ஏதாவது apart from this matter?
MMNCB,
What is that?
multifocal motor neuropathy with the conduction block.
Sensory. He has sensory also.
Yeah.
Yes,
Sensory.
sir. With the sensory paraproteinemia.
Amyloid வருமாமா?
Amyloidosis, in amyloidosis, small fiber neuropathy is the predominant feature.
அது இல்லம்மா, upper limb first, lower limb
Upper limb வருங்க sir.
வருமான்னு கேக்குறேன்.
Yes, sir.
So that is another one
Angio.
you'll have to consider.
Yes, sir.
And it says, I mean, not in this case.
Hey.
When a question
Okay.
is asked which one upper limb,
திடீர்னு ஆடியோ குறைஞ்சு போச்சு.
then you will
Yes,
have to
sir.
consider that.
Or good
ஏன்னா
afternoon.
அவங்கதான் பிரச்சனையா, அவங்கதான் ஏதோ பிரச்சனை பண்ற மாதிரி இருக்கும். முதல்ல ஒழுங்கா வந்துச்சு,
இல்ல சார்.
நல்லா கேக்குது சார்.
சுத்தமா இல்லை ஆடியோ.
அப்படிங்களா? எங்களுக்கு நல்லா கேக்குதே சார்.
சரி.
Okay, those are the questions which we asked. Now, what do you think?
So CADP, symmetrical wasting was there, sir. So may think MADSM also possible, sir.
அதுவும் CATP, right? Okay. அப்புறம் okay, continue then the investigation.
Yes, sir. Investigation, complete blood count was normal, renal function test normal, liver function test normal, lipid profile, total cholesterol normal, blood glucose 146 milligram per deciliter, HbA1c 5.9%, peripheral blood smear normal, reticulocyte count is 1%, ESR 32 mm in half an hour, 75 mm in 1 hour, CRP normal, TSH also normal, and echo scan 34% EF, hyperkinesia for left ventricle, chest X-ray normal, and my nerve conduction study. In sensory nerve conduction study, velocity decreased in both median and ulnar nerve, and motor nerve conduction study, velocity decreased in both upper limb and lower limb except ulnar nerve, amplitude decreased in both median and right peroneal and left tibial nerve, suggestive of sensory motor axonal polyneuropathy.
Can you blow up, please? Can you show? Blow up on. We'll see the parameters. Can you just zoom it, please?
Zoom பண்றது. Zoom.
அபிராமி பண்ணி காமிச்சாங்க இல்லையா?
Yes, sir. I'll try, sir.
Okay. Yeah, that's correct. Values matters. Move the slide a little bit.
Yes.
Oh, that's true. So conduction velocities are borderline. It's
Yes, sir.
50, it is 42. I presume this is median. Distal
என்ன 42?
50, 48, and the left median nerve. Okay.
Amplitude reasonable. I am interested in the cardiac finding. My echo 35% போட்டிருந்தீங்க. Was there any wall motion abnormalities?
Is there, sir? Hyperkinesia of left ventricle was there, sir. A non-CAD patient, sir.
CAD, that's correct. She put
Yes,
in
sir.
என்னது?
Non-coronary artery disease patient only, sir, under medication.
CAD, right.
ஆமாங்க sir.
She had already happened.
Okay.
Okay, ma'am.
Shall I proceed, sir?
Yes, please. Zoom out பண்ணிங்க அப்பதான். Come back to the normal presentation.
Yes, sir.
Okay.
Yes, of normal.
Yes, sir. Viral marker and VCTC also normal. Viral marker and rapid RPR test also negative. My MRI finding. So the long segment linear T2 hyperintensity involving posterior column in cervical cord from cervicomedullary junction to C5 vertebral level.
Entire cord or part of the cord? Partial or total?
Looks like only
The partial, only posterior column only.
The sagittal coming through.
Posterior column isn't.
Mostly posterior situated. Okay.
Yes, sir. Axial cut, so the inverted V signs in dorsal column. MRI brain normal, sir. So we did serum vitamin B12, which showed more than 2000 picogram. Homocysteine and methylmalonic acid value were normal. Both eye fundus examination were normal. We did a MRI cervical spine contrast. There were no enhancement. CT chest, CT abdomen normal. PET whole body scan is normal. So we tried to rule out the Sjogren and SSA and SSB antibody negative. Serum electrophoresis also normal. Serum. So finally, we did serum corpuscle, which is showed 67.93 and low. And serum ceruloplasmin is normal. Serum zinc value were normal.
So copper myelopathy.
So probably copper deficiencies. Shall we take it as a copper radiculoneuropathy, sir? We have doubts, sir.
Proceed, ma'am. Proceed. You would have done
We did a bone marrow biopsy, sir, to rule out because vitamin B12 were more than 2000. So we tried to rule out the subleukemic conditions and myeloproliferative disorders. So we did a bone marrow biopsy, sir, which is showed erythroid hyperplasia only.
So what are the features of a copper myelopathy? First thing, myelopathic feature enna irukku patient clinical what are the features of copper myelopathy? Somebody has asked whether you check urine copper and zinc and potrukanga.
Zinc value were normal, sir, but we didn't do urinary copper, sir. Patient went in at request discharge, sir. We didn't proceed further test, sir.
Okay. So did he have any myelopathic signs?
Sir, myelopathic signs because of that dissociative sensory loss pattern, posterior column, dissociative posterior column pattern, only the positive finding to rule out the myelopathy, sir. And vibration sense absent above L1 level. That also the point for to rule out the myelopathies.
So features of copper myelopathy.
So
clinical and radiological.
So radiological finding in copper myeloradiculoneuropathy also will show.
Is it a copper myelopathy or is it a copper myeloradiculoneuropathy?
So yeah, I'm thinking absent because of absent reflex in all levels.
No. I'm talking of literature. I'm asking you about literature. What is the literature mention about copper? Does it produce a myeloradiculoneuropathy?
Both were present, sir. Both copper myelopathy and copper myeloradiculoneuropathy also present, sir.
Not present, Amma. Are they described in literature?
There is there, sir, in literature. In journal publication also there is.
Okay, continue. Continue with your presentation.
So final diagnosis, we concluded in these two, sir. Even though vitamin B12 and methylmalonic acid and homocysteine values were normal, we thought to rule out a central deficiency of vitamin B12, sir.
Why do you still think of B12, man?
Sir?
What makes you still think of B12?
Because in central deficiency of vitamin B12, there were vitamin B12 and methylmalonic acid homocysteine values will be normal, sir. One literature, one journal was.
What makes you think this is B12? Clinically, what?
Yes, sir. Serum copper value, only the positive finding in this case, sir. So we try to rule out a common cause like vitamin B12 deficiency in this case, sir. Literatures were supported for this, sir. One literature in preprint article, which showed transcobalamin receptor autoantibodies in central vitamin B12 deficiency. In this antibodies against CD320, which blocks the vitamin B12 absorption in central level, which will lead B12 deficiency in central level that will cause these findings. Also, copper deficiency myelopathy. The myeloradiculoneuropathy also there, sir, but I didn't put that article. In this article, there were showed normal ceruloplasmin and zinc level also will produce, will take it as a copper myelopathy as a cause, sir.
But in this patient, there are no hard signs of myelopathy at all, isn't it, ma'am?
Sir,
Are absent, planters are flexors.
ஆமா அந்த சம்மரிக்கு போமா, சம்மரி ஆஃப் கிளினிக்கல் ஃபைண்டிங்ஸ் போடுங்க, எல்லாம் போட்டிங்களா, அதை போடுங்க. Continue with the findings. சரி, அப்புறம்
sir, 60. Shall I read, sir? This.
இல்லம்மா, அடுத்த ஸ்லைடு. கிளினிக்கல் ஃபைண்டிங்ஸ் அடுத்த 2 ஸ்லைட்ல இருந்ததுல்ல,
இதுக்கு அடுத்த ஸ்லைடு.
How do we explain this degree of wasting, amma?
Sir, radicals, asymmetrical wasting can, radicals involvement can explain this.
Radical or
axon radical, axon motor radical involvement will explain this asymmetrical wasting, sir.
சரி, except for எல்லா ரிஃப்ளெக்ஸும் down.
Yes, sir.
What is the myelopathy there?
Sir, the myelopathy, it's not a myelopathy, it's a tractopathy, sir. The posterior column is involved as evidenced by the reduced vibration below D6 valve and sensory ataxia. So selectively posterior column is involved, tractopathy.
Okay, sir, but how can we...
If it's a tractopathy, allegation, why is it, why are the reflexes absent and why is there so much of wasting?
Especially proximal muscles, sir. So wasted.
So both distal also wasted in upper limb, sir. So we can think both radical and nerves also included in this case, sir.
So we have to think of anterior cell loss, sir. Diffuse anterior cell loss.
That's what we suspect, because the anterior cell involvement can cause significant waste.
அதெல்லாம் SACD-லயோ காப்பர் myelopathy-லயோ இருக்கா, மென்ஷன் இருக்கா? That's what
copper myelopathy can present with various signs, sir. That so far around 40 cases have been reported. All the cases showing neuropathy as well as B12-like features.
Yeah, B12-like. That's right, B12-like. It's a difference for SACD. So here it seems to be more in keeping with the copper myelopathy, but you are consistently harping on B12 deficiency. Adan yen kekran.
Sir, can I come in, Vijayan?
Please, Vijayan.
Sir, why do you want to harp on copper myelopathy, sir? Copper is low normal in this case. It's not deficient.
Where எதுவுமே fit ஆல findings la.
Sir, that doesn't mean it could be copper myelopathy.
That is the only finding which we have. Copper is low.
But it's just low, sir. It's not even very low. It's not deficiency.
Yeah, agree, sir.
It's not deficiency.
The literature says copper myelopathy is almost equal to vitamin B12 deficient myelopathy.
It is equal.
But
it is not deficient here. It's definitely not deficient.
Here vitamin B12 is normal, but this is slightly deficient. I don't give importance to that.
Sir, how can we give importance to a low normal value? It is not deficient to produce symptoms. You should be very low to produce symptoms and signs like this.
Vijayan, what else is it?
Sir, why not simply match them again? CIDP with the card findings. It can happen.
CIDP, yeah.
It's MADSAM, a variant of CIDP with central demyelination.
Electrophysiological findings is not in keeping with CIDP.
MADSAM, we discussed MADSAM, isn't it, sir?
Not in this patient.
Okay, fine.
Sir,
Sir, I think MADSAM we cannot explain the cervical cord findings, sir. Posterior column involvement in the
Any
typical MRI.
CIDP can have central demyelinating findings also. Any CIDP
But do you
can
get
have
it
central.
posterior column
In
alone,
fact,
sir?
described even in
long
GBS. Why do you
segment,
want to consider copper? Copper
Is
is
a
not
long
deficient,
segment,
it is low, that's all.
This is a predominant involvement
Somehow
of
I can't accept the diagnosis of a copper deficiency in this case.
Prasanna Soumitra, EMG பண்ணீங்களாமா?
We didn't
There's a
do
question in the chat box also, EMG.
No, sir, no, sir.
We are talking about anterior answer எல்லாம்.
Sir, wasting is very clear, sir. EMG is not going to give anything other than the neuropathic
இல்லம்மா,
EMG pattern.
anterior answer involvement இருக்குன்னு நம்ம anterior answer suggest பண்றோம்ல.
Vijayan sir.
EMG ல இருக்கான்னு தெரியணும்ல.
Vijayan sir, give importance to MRI findings.
Yes, sir.
No, Vijayan கேக்குறாரு allegation.
என்ன சார் கேட்டீங்க?
You give me some importance to MRI findings.
MRI findings can occur in MRI. Central demyelination can occur with many cases of peripheral
It's
demyelination.
only a dorsal column is enhanced.
It's a well-known
High
phenomenon.
intensity, as similar to that of the B12 deficiency.
இதுல posterior column மட்டும் தான் சார் என்ன
posterior column மட்டும் தான் இருக்கு அதுல இந்த MRI-ல. We need not. Why do you want to call it a myelopathy still? எனக்கு தெரியல.
Inverted V எல்லாம் இருக்குப்பா.
We are calling tractopathy.
Okay.
But still the wasting is a red herring, sir.
Wasting is a red herring.
Wasting red herring.
இவ்வளவு severe wasting.
Arul,
I don't know.
posterior column involvementல ஏமா reflexes எல்லாம் லாஸ்டா இருக்கு. Peripheral nerve involve ஆகாம, radical involve ஆகாம, with just a tractopathy, why are the reflexes lost?
Sir, this is not a tractopathy alone, sir. They are peripheral now also involved, sir. And involved.
நம்ம extend பண்ணிட்டே போறோம், right?
Sir, it is a myelopathy as evidenced by the MRI. Yeah. And as well as the peripheral nerve involvement from proximal to distal, probably under cell involvement also with the diffuse nerve involvement. Diffuse
clinically radiculoneuropathy, MRI, myelopathy.
MRI, sir, in most of the conditions of peripheral demyelination, we know that central CNS demyelination does occur.
That is true. But not this MRI.
Why do you want to give importance to something which is not there clinically?
Not this MRI appearance.
Vijayan sir, central demyelination different from posterior column demyelination of classical nature, where you can
fine, sir, accepted. But why do you want to give, when there is nothing clinically, why do you want to give importance to that? And it's just an additional finding.
So we didn't get any clue. So we thought we got only low copper value. So we thought it is only copper deficiency. Could be a possible phenomena. And the copper level, I think, can vary
copper
from,
is not deficient, sir. Definitely not deficient in this case.
No, up to 72, above 75 is normal, sir. It is.
So deficiency, classify pananona, it should be much lower. That if it's so deficient to produce so much wasting.
Cutoff value for neurological manifestations, we have to see.
I have checked, sir. There nothing is found. Values below 45, they were reported with the copper deficiency. It is 67.
இதுக்கு ஏதோ genetics help பண்ணுமாப்பா?
Genetic in copper deficiency க்கு வேணா help பண்ணலாம் சார். ATP7A gene mutation that can lead to copper deficiency, sir. So to rule out that, we can do genetic test.
The copper deficiency can occur with copper deficiency can occur with genetically or excess zinc intake. Or it can
this is
occur
not copper deficiency at all. That is the point.
But sir, copper deficiency in serum level, in central level, much more earlier than serum level. Like that literature says.
Okay.
So like treatment-wise, is it important? Treatment-wise, is it important? Are these reversible with treatment?
Yes, sir. But hematological manifestation can reversible, sir. But neurological manifestation, only 1/4 of the individual patients only can recover from this illness, sir.
With what treatment?
With copper only, sir. 2 to 4 milligram per day.
So
with preceded with IV copper.
So it will be useful to have a genetic study done. Doesn't matter or treat. I mean, if not, treat with copper and see what.
If not treat with copper, copper deficiency is a treatable condition, sir. If not treat, will leads more disability.
So start the treatment with copper. Anyway, your B12 is more than 2000. We are not going to give B12.
No, sir. According to that preprint journal, we can give a B12 also, sir. If there is a central deficiency of vitamin B12, in spite of serum values normal or high.
How do you find out the central deficiency of B12? No?
Sir, we can.
We have to do a CSF B12, sir.
Sorry?
CSF B12, we have to do it, sir.
Okay.
CSF B12 in CSF.
I think it is being done. It's not being done. We can do that. It's worth it because both are treatable causes. It's worth it.
We have treated this patient with B12 plus steroids, sir, thinking that it could be an autoimmune condition, so that we can overcome the blood-brain barrier.
Okay, what happened?
Inside.
What happened with treatment?
The patient is still on treatment, sir. We have to wait and see.
Why not?
And
copper?
Also copper is getting.
Why not?
Copper also is getting.
Copper also
is getting copper also, sir.
Oh, then we won't know which is making him better if he gets better. Okay, doesn't matter. He should get better. Yes, Arul Selvan.
Sir, it was a wonderful presentation, but we still, it's a potentially treatable case. We will continue with the copper and give us a feedback how it's going to improve.
Sumitra.
Yes, sir.
I'll give you a person who is doing copper myelopathy. We can check with him whether this is acceptable as a copper myelopathy. What is the copper level?
Sir, 67, sir.
67.
Yes, sir.
67 enna units adu?
Sir.
Huh?
1 second, sir.
Microgram mari sir.
Microgram per deciliter.
Okay.
67.93. In central deficiency, much more earlier than serum copper deficiency, sir. Like B12.
அது என்னமா CSF தானமா CSF B12 பார்க்க முடியாதா?
We searched it, sir, but nowhere tested, sir.
Okay. I think somebody from Bangalore discussed this B12. Okay. Let's see. I'll see whether it's being done anywhere. Okay, ma. Thank you.
Sir, I have a doubt, sir.
Somebody is asking a question. Tissue copper level. Edo mudiyumaannu.
Liver biopsy panni vena tissue copper pannalam sir.
Yeah.
Cell deficiency, it won't help tissue.
Tissue copper and liver biopsy paakalam andan ketirukanga. It is very possible to have a normal or low normal serum copper with low tissue copper and liver biopsy, which should be done in this case. Arun Kumar has put up this on the chat box.
Did you check
peripheral smear la edavadhu theriyuma?
Peripheral smear la theriyum. Microcytic macro and cytic anemia will see, sir. And erythroid precursors. In early copper deficiency, we can see erythroid precursors and myeloid precursors.
So, have we seen that?
We did, sir. Only erythroid hyperplasia only is there, sir. It's also one of the early marker for iron deficiency. Copper deficiency also leads iron deficiency, sir.
Okay.
So we can take it as one favor point.
Okay.
Have you done the serum ceruloplasmin?
Yes, sir. Normal, sir.
Done. அந்த ஸ்லைடு போடுமா? அந்த இது எல்லாமே போட்டியா? 19.73.
Low normal. Low near normal, sir.
15 is lowest, so that's okay. Zinc on the 63.38 of 54 is low normal. This on the 74 low normal. 74 is Lower limit of normal.
Yes, sir.
Copper.
Yes, sir.
Okay.
One studies were published, sir, on 2 cases, sir, published in this journal, J Spinal Cord Medicine. In that, one patient has a serum copper concentration was low and normal ceruloplasmin and zinc values.
No, low na, how low? That's the question.
0.6, the 0.6.
Deficiency. What is deficiency?
60
How much should it?
microgram. Sir, one book says less than 70, sir. One book says less than 65.
Hey, it's almost there. 67 is a gray zone between 65 and 70. Anyway, I'll check with Neeraj. Right, let's see.
Central deficiency literature, sir.
Conclusion.
Conclusion, there is antibodies against CD320, sir, which blocks B12 absorption. That leads central deficiency of B12. So, so final conclusion between this and this central deficiency of vitamin B12 or copper deficiency of deficiency induced myeloradicule neuropathy.
Okay. Thank you very much. Thank you very much. All interesting.
Sir, one doubt, sir.
Arul Selvan.
Yes,
Pose
madam.
it to this. Is doubt kekranga?
Tell me, ma'am.
Sir, we have that dissociation in upper limb position sense impaired, lower limb vibration impaired, sir.
Check again.
I checked, sir. Normal only, sir. Vibration is normal in upper limb. And position sense normal in lower limb. So,
as allegation has been saying, tractopathy, in the tractopathy, is there a differential involvement of JPS and vibration? It is there. It is there. But does it cause upper limb and lower limb difference? No allegation?
Yes, sir.
Solunga.
So, any posterior large fiber neuropathy or posterior canine, all 5 posterior column sensation need not be lost, sir. Anyone may be impaired.
That's correct. That's not சொல்லிட்டேன். ஆனா lower limbல ஒண்ணு upper limbல ஒண்ணுன்றது அது இருக்குமா அது மாதிரி ஒரு limbல வந்து vibration sense is preserved whereas the JPS is down. In the lower limbsல vibration sense is affected, JPS is preserved. அது மாதிரி வருமா? We don't know. அது மாதிரி ஏதாவது description இருக்கா?
I'm not aware of this, sir.
Okay.
But we found one line from Dijang, sir.
Good.
Is it suitable for this, sir?
Tell us. Tell us the Dijang line.
Yes, sir. This is the Dijang line, sir. Posterior column pathway. Fibers from posterior column to dorsal root ganglion, which enters spinal cord, which bifurcates into posterior column and accessory pathway, sir. Posterior column, as usual, enters into medial lemniscus, thalamus, and somatosensory cortex. In accessory pathway, which ascend ipsilaterally in dorsolateral funiculus, spinocervical tract, which enters into lateral cervical nucleus, C1, C3 level, which cross. And
அடுத்த slide போட்டீங்களா அதான் informative. Next slide போட்டீங்களா? What does it say?
Say.
இன்னொரு slide போட்டீங்களா? அத சொல்ல இதான் முக்கியம். காமிங்க.
This accessory pathway related in the point வருதுங்க sir. This divergence one straight up posterior column pathway, இன்னொன்னு accessory pathway via lateral cervical nucleus, which cross and acusate and medial lemniscus and thalamus and cortex, sir. This divergence of position sense and vibration sense pathway may partially explain the dissociation occasionally encountered clinically between changes in position sense and vibration. In subacute combined degeneration, it is not uncommon for vibration loss to be much worse than position sense loss.
That is okay, but the point is in how differential involvement in upper and lower limbs.
Because of this accessory pathway, and one more point was there in Adam, sir, not all proprioceptive fibers ascend to gracile and cuneatus. Some proprioceptive fibers leave posterior column posterior column in the lumbar region and synapse with secondary neurons in the spinal gray matter and ascent in the ipsilateral posterolateral funiculus. So only cutaneous fibers continue to gracile and cuneate plane சொல்லியிருக்காங்க சார். இந்த பாயிண்ட் நம்ம மேட்ச் பண்ணிக்க முடியுமாங்க சார்?
எனக்கு புரியலம்மா.
Yes, or else it can be explained by the classical example of length dependent vulnerability, sir. Gracilis tract travels long distance, so the whole limb may be affected first. Cuneatus in the upper limbs may be affected later, sir.
சரி, பட் டிஃபரன்ஷியல் இது மாதிரி வைப்ரேஷனும் போஸ்டீரியர் சென்சேஷனும் இருக்குமா? போஸ்டீரியர் காலம் ஜாயிண்ட் பொசிஷன்ஸும் இருக்குமா? whether it is gracilis or cuneatus tract எதா இருந்தாலும்.
Partial involvement can lead this type of condition. So findings, sir.
Okay. தெரியல, we don't know.
Patchy and early lesions and partial lesion. Patchy involvement.
Okay, ma. Thank you. Thank you so much. Arul, நீங்க தான்.
Sir, I thank the presenters, Sashidhar, Abhirami, and Sumitra for presenting excellent cases. It's been wonderful, very informative. We learned quite a lot.
And the teachers, mentors, Thiruvarachalvan, Shivakumar. Yes.
Also thank
thank you profusely for Professor Natarajan and Arulcharan for this opportunity, sir.
Thank பண்ண வேண்டாம்ப்பா. We need to thank you all for letting us know.
Sir,
you are taking all
I
pains to educate us.
Sir, I am passing it to my postgraduates, sir. They all worked at the cases and they are interested to present the cases and they have done it, sir.
Very good, very good.
And well done to the presenter. They have done.
Yeah, congratulations to them. And please continue. The third year postgraduate should pass it on to the second year and the second year to the first year. Let them continue to do it.
And thank Professor.
Thank you, sir. If you are continuing meeting, we will do it, sir.
Yes, sir, please.
Thank you, sir.
Professor Alagesan. Thank you, Arul.
Thank you, sir.
Very nice, very good cases, Arul.
Definitely, sir. Excellent.
Thank you, sir.
All in your lap. All peripheral nervous system in your lap.
Thank you, sir. Thank you.
Thank you so much. Thank you.
Thank you, sir. Thank you.
Yes, please. And thank you, Sun Pharma, for all the logistics and support you've been providing. Dinesh இருக்கீங்களா? சண்முகம் இருக்கு. யார் இருக்கீங்க?
சார் இருக்கேன் சார். Thank you, sir. Thank you.
Thank you so much. Thank you.
Thanks.
Can we leave?
Yes, sir. We can, sir.
Thank you. Thank you. Thank you.
Thank you, sir. Thanks.
Thank you, Vijayan.